करना मेरी वॉल्यूम उधर से ऑन। हाँ हेलो जूम को देना साउंड। हेलो 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 हाँ हाँ हेलो एवरीवन हेलो गुड मॉर्निंग।
So you'll be given 5 minutes each.
Right. Me, but okay. Because the other two judges who were there, like Ajay Kapoor, he was also not part of yesterday.
No, we can take
अच्छा, मैंने दो
What
की देखा
decision will be.
नहीं I was thinking it's better to have at least odd number
If you
तीन
want,
तीन
if
होने
you want
चाहिए.
me to be there,
I think it will be better.
decision will be yours. I'll be sitting.
No. At least there should be three. तो
Okay.
बड़ा आप समझ रहे हैं मेरी बात. मतलब it's a new presentation. ना? We are not going to carry forward what they have done yesterday. We are going to start off with how they present and everything is going to be a new thing.
So Deepak sir is on the way. If
So
you
me
want me to be.
and I was saying कि at least there should be three people.
Okay, I'll be
present.
sitting. If
So that
you agree.
we agree two people can be, we can be biased also, right?
No.
नहीं, it's always better to have an odd number.
I'll.
नहीं?
ये करेंगे।
अच्छा.
हम लोग एक बार पूछा था 10 बजे तक रुकिए। Please come. So, Dr. Pradeep Gar. Thank you, sir. So the first presenter, please come up with the diet. So, Dr. Rajeshwar Singh Jamwal. So I think you are from Shri Mata Vaishno Devi University. Welcome, all the best. So he's presenting on genetic variants of TERT lead to increased susceptibility towards non-small cell lung cancer in North Indian population of Jammu and Kashmir. Alright, good, all the best.
So should I start? So good morning, everyone. Myself, Rajeshwar Jambal, and today I am going to present on genetic variants of TERT led to the increased susceptibility towards non-small cell lung cancer. So coming to the introduction, lung cancer is the uncontrolled growth in abnormal cell, and it's of two types: small cell lung cancer and non-small cell lung cancer. So incidence of lung cancer worldwide, it accounts for 11.4%, and in India, it accounts for 11.9%. If we talk about the J&K, the population we are studying, it accounts for 23.5%. So coming to the gene that we have selected for the study, we selected this gene on the basis of the exome study and the previous literature available. So it's a ribonucleic protein that protects the telomere ends by adding the telomere repeats units. The overexpression of TERT can result in the cell immortality and can cause cancer. So it's located on P arm of the chromosome number 5, and the figure 5 shows its location. Coming to the pathway, as we all know, after each cell division, the chromosome shortens. So there are certain mechanisms inside our body that protects the chromosome. One is the Shelton complex and other is the telomerase complex. So Shelton complex controls the activity of the telomerase complex. If the telomerase complex is overexpressed, it can cause the immortality and lead to the cancer. So the aim of the study was to check the association of these genetic variants with non-small cell lung cancer. Coming to the methodology, we collected a total of 659 samples, out of which there were 254 cases and 405 controls. So firstly, we got the ethical permission from our university for sample collection. We collected 2 to 3 ml of blood in EDTA vacutainer and then stored them in -20 because we have to isolate DNA later on. So the criteria for the sample collection was, we took age, gender, weight, height, match cases and controls, and type of non-small cell lung cancer, stage of the cancer, whether they were metastatic, non-metastatic, and if they were having any family history or history of smoking. So these samples were subjected to DNA isolation. Then we checked the quality and quantity of these samples by agrosia electrophoresis and nanodrop method. And these samples were subjected to TACMan genotyping. Coming to the principle of TACMan genotyping, it's a gold standard technology for genotyping processes. It's similar to the normal PCR, but the only difference is the probe that we are using. It consists of 2 components, that is fluorophore and quencher. it is highly specific for the region that it is designed for the allele that we are searching for. So this is the gel image that we got after the DNA isolation, showing the quality of the DNA. All these samples were above 200 nanogram per microliter that we got from the nanodrop. So these are the conditions for the real-time PCR. We used 2.5 microliter of UNG master mix and 0.25 microliter Tachman probe and 3 microliter of DNA whose concentration was 5 nanogram per microliter, and rest volume was filled with nucleus-free water. So the thermal conditions were 95 degrees for 10 minutes, then 95 for 15 seconds, then 60 degrees Celsius for 1 minute. The step second and third were repeated for 40 cycles. So these are the clinical characters that we got from the patient. We have a pre-designed questionnaire and we got them filled from the patients. So this is the amplification plot that we got after the PCR that shows the sample started amplifying after 22nd cycle. It depends on the concentration of the DNA. If we will increase the concentration of the DNA, it will start amplifying from 10th or 12th cycle. That all depends on the concentration. So this is the dual scatter plot representing the homozygous mutant alleles and wild alleles and heterozygous alleles. So after the genotyping, we applied the stats on this data and we observed that both these SNPs were significantly associated with the non-small cell lung cancer. So to observe the maximum effect, we applied logistic regression. Under dominant model scenario, we observed that both of these SNPs were significantly associated with the odd ratio of 1.47 and second with the odd ratio of 1.67. Firstly, we got the odd ratio, and after adjusting it for smoking, we can see the odd ratio increased. So as these two SNPs were from same gene, we did the haplotype analysis and we observed that all the 4 haplotypes are significantly associated, and one out of them in CA haplotype, the frequency was more in controls, and in other 3 haplotypes, their frequency were more in cases. So they were increasing the risk of lung cancer in our population. So coming to the conclusion, in this case control association study, we took 659 samples and it was observed that these were significantly associated with lung cancer. So this gene increased susceptibility toward non-small cell lung cancer patients. And in the modern era of medical sciences, due to the increase in drug resistance, it is very important to develop an effective treatment. So targeting these genes can help us increase the chemo sensitivity and reduce the drug resistance. So this data supports the notation that this variant can be used as a prognostic biomarker. These are the certain references, and thank you. For the certain techniques for real-time PCR, you can do it in 2 or 3 hours. The difficult part is sample collection. In lab work, we can process it in 1 week. At a one time, we can process it in 1 machine.
And how you find your study is going to help the clinician?
Yeah, that we have to do functional analysis. We are planning an experiment to do the transcriptome analysis to check the expression of the gene in our population. So as this gene is providing immortality itself, so it is increasing as we give the drug treatment, the cell should die. But this gene is providing immortality. So we should talk to this gene so it can increase the chemosensitivity.
Have we got any gene blockade? क्या हम इस gene को block कर सकते हैं?
Yes, there are certain things we can use siRNA, we can use CRISPR to delete.
I have a question. Why did you choose this liquid biopsy? I mean, blood samples and not the tissue sample?
Sir, we have collected the tissue samples also, but for DNA isolation,
DNA,
blood is easy. So
No,
for
that
the
is easy, but-
transcriptome analysis or RNA analysis, for that we need tissue. And it is easy to isolate DNA from the blood sample.
No, it is. But basically, if you see lung cancer,
Yes, sir.
liquid samples are still not the category 1 recommendation.
Yes,
It's
sir.
the tissue which actually tells you whether it is the right way to go forward. So because we have many researchers have come, they need the fresh biopsies.
Yes, sir.
Intraoperatively, we give the samples and then they do the DNA extraction and not on the FFPE blocks.
Yes, sir.
I think that is one limitation of your study. Okay.
Sir, it was a genetic study, so we genetic study, so we took the DNA samples. Na? For the RNA analysis, that we take tissue samples. We have taken 30 tissue samples from Dr. Subhash Bhardwaj.
But that they are the on the blocks, na?
Yeah, sir, blocks.
So blocks DNA extraction is an issue.
Yes, sir.
Thank you. The next candidate, Dr. Anveshi Sharma. She's come from, I think, JMC Srinagar or Jammu. JMC Srinagar. Okay. All the best.
Good morning, everyone. I'll be presenting a case that was that we treated in our department in Srinagar. It was nasopharyngeal carcinoma with an unusual metastatic presentation. Nasopharyngeal carcinomas have a high predilection for regional lymph node metastasis. Up to 85% of the cases present with lymphadenopathy at diagnosis. The pattern of nodal metastasis in nasopharyngeal carcinoma follows an orderly spread down the neck with infrequent node skipping. The most commonly involved regions include the retropharyngeal space, the level 2, level 3, level 4, level 5, followed by level 1B and the supraclavicular nodes. The parotid group of nodes classified at level 8 in the latest international consensus guidelines for the nodal levels are also at risk of harboring metastasis from the nasopharynx. The occurrence of parotid lymph node metastasis has been reported in several studies and is approximately 1%. The prognostic significance and clinical staging systems for parotid lymph node metastasis have not been investigated in nasopharyngeal carcinomas due to the low incidence of the parotid lymph node involvement. Neck node metastasis from occult primary constitutes about 5 to 10% of all patients. In many incidences. Neck node metastasis is the only manifestation of this disease. And sometimes even endoscopic examination or biopsies of the nasopharynx, they fail to detect the primary because of submucosal and infiltrative nature of the nasopharyngeal carcinoma. The difficulty in diagnosis of this leads to the delay or inadequate primary treatment, which results in suboptimal therapy. So this case was a 55-year-old male with no known comorbidities and presented with swelling in the left upper side, upper neck, which was level 2 node for the last 3 years. And the surgeon decided for an excision biopsy, and which the histopathology of which suggestive of basal cell adenocarcinoma with lymphocytic infiltration of the submandibular gland. The patient was sent for follow-up, and he develops a recurrent swelling after 1 year. FNAC suggests a lymphocytic infiltration of the submandibular gland. The oral examination at that time is still normal. MRI neck suggests enlarged 2.5 to 2.5 into 1.2 centimeter level 2 node, a few subcentimetric nodes at 1B level, which were suggestive of inflammatory nature. A true cut biopsy was suggested of poorly differentiated carcinoma. The biopsy sample was sent for an IFC. CK-P14 CKIT were positive, and this was suggestive of metastatic basal cell carcinoma, adenocarcinoma. And then the patient was advised a PET CT and mildly active nodular lesion, which was about 2.3 into 1 with SUV marks of 2.1 near the inferior angle of the left parotid, along the lateral surface of the left sternocleidomastoid muscle with preserved fat planes. And this lesion was closely abutting the retromandibular vein. The patient underwent a left-sided parotidectomy with ipsilateral nodal lymph node dissection from level 1A to 5. And the histopathology at this time was suggestive of metastatic nasopharyngeal carcinoma. The patient presented to us post-surgery, and the histopathology being suggestive of a nasopharyngeal carcinoma, we sent the biopsy for an IHC. It was positive for P16 and P40 and negative for TTF, PAX8 and GATA3. And then the sample was sent for EBER, and it was positive. So there was now the confusion was because 5 to 10% of the parotid tumors do have Epstein-Barr virus positivity. And the nasopharyngeal biopsy was normal. So we didn't know the primary was either salivary gland or the nasopharynx. And the PET CT and MRI were unremarkable for any nasopharyngeal lesion. Then the initial biopsy, the excision node that was taken 3 years ago, it was taken, the review biopsy of that was done. And the pathologist was of the opinion that there was no evidence of any native salivary glands in the specimen. And then the case was discussed again with the reporting pathologist, who was of the opinion that the lesion in the parotid at this time is actually a node, an intraparotid node, well encapsulated. And post this, the treating physician had to take a decision either as a salivary gland tumor or a nasopharyngeal carcinoma. So it was decided to be treated as a nasopharyngeal carcinoma, and the patient received CCRT with concurrent cisplatin and has been doing well post the treatment. This report presents a rare case of involvement of parotid lymph node, which according to the study is about 1%. Nasopharyngeal carcinomas present with a heavy disease burden in level 2, which may cause a blockage of the normal roots and include retrograde tumor spread to the parotid lymph nodes. The prognostic value and the staging category of the parotid lymph nodes in the nasopharyngeal carcinomas is still unknown due to the rarity of the case. However, the close association between the Epstein-Barr virus and the nasopharyngeal carcinoma is well known. The patients with Epstein-Barr virus positive lymph nodes in metastatic carcinoma of unknown origin, the most common primary sites include the nasopharyngeal carcinoma, 51%, salivary gland tumors, 24%, lungs, 7%, and the oropharynx, 3%. In this case, Epstein-Barr virus encoding RNA in situ hybridization was used to diagnose the patient of an unknown primary tumor, and it is well known that Epstein-Barr virus and nasopharyngeal carcinoma are strongly correlated. Eberish technique is used to identify the nasopharyngeal histologies of neck masses and unknown tumors. Thank you.
I'm sorry, I missed whether you had done an MRI to look for the primary in the nasopharynx?
Huh?
Was an MR done, contrast enhanced MR scan,
Yes.
and no lesion was picked up in the nasopharynx?
No, ma'am.
Thank you.
May I invite next speaker, Dr. Surbi Negi. She's come from Himalayan Institute of Medical Sciences. She'll be speaking on therapeutic management of carcinoma cervix in elderly patients with radiotherapy. This is a single institutional study. All the best, doctor.
A very good morning to all. Myself, Dr. Surbi Negi, and I'm presenting my presentation on the topic therapeutic management of carcinoma cervix in elderly patients treated with radiotherapy. And my study is a single institutional study. So talking about the cervical cancer, while the global incidence of cervical cancer is on decline due to implementation of various screening programs, the incidence of cervical cancer in elderly female has remained unchanged. It has been observed that the quarter of cases of cervical cancer occur in the elderly age group. Treatment decisions in older females are complex as they tend to be weaker and have a number of multiple comorbidities. For all these reasons, treatment of cervical carcinoma is not consistent with the geriatric population, and the prognostic factors that are able to predict the survival of cervical cancer for the patients who are over 60 years of age have not been investigated extensively. Talking about the aims and objective of my study, it is a comprehensive analysis of the outcome of the elderly patient diagnosed with cervical cancer and treated with radiotherapy. Talking about the material and method, the duration of my study was from 2009 to 2021, and the total number of diagnosed cervical cancer patients were 876. A total number of 186 patients met the inclusion criteria. And the inclusion criteria included patient diagnosed with cervical cancer, age more than 60 years of age, FIGO stage 1B to 4A, ECOG performance status 1 to 3, and the exclusion criteria included previous pelvic radiation or any synchronous secondary malignancy. Talking about the statistical analysis, it has categorical variables which were expressed in counts and percentage. The Kaplan-Meier approach was used to analyze the overall survival and disease-free survival in the study of population. P-value less than 0.05 was considered significant for all statistical analysis. Coming to the results, for the patient we have took, the patient characteristics were mean age 75.5 years, lowest being 60 years and highest being 86 years of age. Patient with ECOG performance status 1 were 2, ECOG performance status 2 were 167, and ECOG performance status 3 was 17 patient. Majority of the patient had the histologically type of squamous cell carcinoma, number being 179, adenocarcinoma 6, adenosquamous carcinoma 1. Patient falling in category of FIGO staging 1B were 5, 2A were 19, 2B were 46, 3A 16, 3B 51, 3C 27, and 4A 22. So this is how we have, this is the flow chart showing the patient selection. Total number of cervical cancer patients we had from 2009 to 21 were 876, out of which 15 patients defaulted, and the number of patients remaining 675 did not meet our inclusion criteria. So the number of patients we were left with were 186, out of which number of patients who followed up were 185, and 1 patient defaulted. So what was our intent of pre-treatment? Palliative, we treated 12 number of patients with palliative intent and 174 number of patients with radical intent. Total number of patients were 174, out of which 72 number of patients were treated with external dose radiotherapy of the doses, 46 grade, 23 fraction, 4 number with 45 grade, 25 fraction, 89 patients with 50 grade, 25 fraction, 6 patients with 54 grade, 28 fractions, 3 patients with 40 grade, 20 fraction, and followed by brachytherapy, in which 85 patients were treated with 9 grade of 2 sessions weekly, 77 patients with 7 grade, 3 sessions weekly, 5 patients with 9.5 grade, 2 of 2 sessions weekly, 5 patients with 6 grade, 3 sessions weekly, 2 patients with 5 grade, 3 sessions weekly. Now, for the response, we had a response assessment of a patient, which was done using MRI pelvis after 6 months of the completion of the primary treatment, in which 68% of the patients showed complete response for the treatment, 15 patients showed residual disease, and 15 patients showed disease recurrence, and 2% showed progression of the disease. What is the current status of a patient? 94 patients are alive, and 92 patients is coming to death. Talking about the cause of death, 45% of the patient died due to disease, and 55 patients died due to other reasons, which included cardiac comorbidity, age-related factors, and other causes like RTA, dengue, pneumonia, etc. Talking about the overall stage-wise survival of a patient with 1B disease, over average survival was 106 months. Patient with 2A stage disease, average survival was 101.54. 2B disease was 99.42. 3B disease was 86.33. 3C disease was 85.30. 4A disease was 82.13. And overall mean survival was 92.09. So majority of the survival was found to be 106 months in FIGO stage 1B as compared to other stages. And overall survival in months was 92.091, which was significant with 95% of the confidence interval. This is the Kaplan-Meier graph showing the stage-wise survival, highest being in stage 1B, which was 106 months. Talking about the disease-free survival in months, patient with 1B disease, the average disease-free survival was 109 months. In 2A disease, it was 106.24 months. 2B disease, 104.76 months. 3B disease, 95.63. 3C, 91. 4A, 82.5. So the maximum disease-free survival interval was 109 months seen in FIGO stage 1B as compared to other stages, and the average disease-free survival was 103.24 months. Talking about the treatment-induced toxicities, which was followed after 2 months of completion of treatment, hematuria was seen in 1% patient, bleeding PR in 1.16% patient, VVF 0%, rectovaginal fistula 0%, vaginal atresia 15%, vaginal atresia grade 4 5%. So this is the contouring. This is the image showing the OAR, rectum and bladder usually, and this is showing 95% of the isodose in the washout phase, contouring of the cervix and iliac lymph node. Concluding about my topic, age is not an independent risk factor for defining the outcome in the survival cancer patients in Indian scenario. Elderly patients with multiple comorbidities may need alteration in the standard management protocol, and the management of cervical cancer must have a radical approach irrespective of the age of the patient. Thank you.
So I must compliment you. You have wonderful data, but beta, your presentation, what are we to learn from it? Did you give cisplatin to anyone?
That ma'am, concurrent CTRT.
So one of the salient features when you're presenting, I mean, your data is very good and you should write a paper on this, but what is it that we are to get from your paper, from your presentation? That is not very clear. In the sense, firstly, I want to tell you, whenever you're making a presentation, don't read everything on the slide. Only the salient feature of the slide has to be read. Survival is never average, it's median, right? What was the 2-year survival? What was the 5-year survival? How does it compare with women who are younger? That is what we want to know from your data, right? You don't have to read out every dose. What you have to say is 50 gray was given to X%, 45 gray to others, and the others we modified. Every value doesn't have to be read. So please, I mean, your work is very good. You just need to polish it.
Thank you. So the next speaker, Dr. Tanvi Mittal. She is also from the Himalayan Institute. So she is presenting her paper, Therapeutic Management of Carcinoma Urinary Bladder with Bladder Preservation Protocol using concurrent chemoradiation.
Good morning, all. Today I'm going to present my topic on therapeutic management of carcinoma urinary bladder with bladder preservation protocol using concurrent chemoradiation. It's a single institutional study. Introducing about the bladder cancer. Bladder cancer is the 10th most common cancer worldwide, which comprises 3% of the whole world cancer brand. It is ranked second amongst the most common genitourinary cancer. It is more common in men than in women. Incidence rate of 9.5 per 1 lakh men, which are approximately 4 times more than those among women globally. The gold standard for managing muscle-invasive bladder carcinoma remains radical cystectomy with pelvic lymph node dissection. The construction of a new bladder cannot fully replicate the original bladder and is linked to acute long-term neuromechanical and metabolic complications. Neoadjuvant chemotherapy is gaining prominence due to high propensity of distant failure in bladder carcinoma, offering a 5% survival benefit at 5 years. Aims and objectives: to evaluate the response. We want to evaluate the response and acute toxicities in muscle-invasive cancer urinary bladder treated with concurrent chemoradiation. The materials and methods required are, so we did a retrospective analysis of patients diagnosed with muscle-invasive bladder cancer treated at Radiation Oncology Department from year 2021 to 23. In the inclusion criteria, we have histologically proven muscle-invasive bladder cancer treated with organ preservation protocol, ages greater than 18 years, ECOG PS1 and 2. In exclusion criteria, we have we exclude previous oncological treatment patients, any other synchronous malignancies, any evidence of distant metastasis. From the year 21 to 23, we took 75 patients who were treated with out of which 45 were treated with radical intent and 30 were treated with palliative intent. Radical was 60% and palliative were 40%. So the 75 patients with muscle-invasive bladder cancer were treated with 4 cycles of neoadjuvant chemotherapy. On day 1 and day 8, we gave them injection gemcitabine 1000 mg per meter square, and on day 1, we gave them injection cisplatin 75 mg per meter square. After that, the patients were planned for cystectomy. They were counseled for cystectomy, but the patients refused for cystectomy, and they were followed by concurrent chemoradiation, which was 64 gray, 30 fractions at 2.13 gray per fraction, along with weekly injection of cisplatin 35 mg per meter square. The response assessment was done by new response evaluation criteria in solid tumors version 1.1. Coming to the results, the total number of patients was 75 and male to female ratio was 4:1. Coming to the pictorial results, out of the 75 patients, 45 patients were treated with radical intent and 30 patients were treated with palliative intent. Out of the total patients, today we have disease 82.2% patients which are disease-free, and local recurrence are in patients comprising 6.7%, and 8.9% patients have distant metastasis, and 2.2% had non-oncological deaths. Out of the total 45 patients, 37 patients are alive without the disease, and patients alive with disease are 3 patients, and 5 patients are dead. Out of the 5 deaths, 3 had liver metastasis, 1 had brain metastasis, and 1 had a cardiac event. So this is a graph showing survival in patients treated with radical intent, showing 80% patients survived greater than 20 months. This is also a graph showing disease-free survival probability in patients in which 82.2% patients survived after 20 months, which were disease-free. This is some contouring images showing the GTV high risk in red outline. GTV high risk comprises of the tumor site, and in the green outline, we see the GTV intermediate risk, which comprises of the whole bladder. And in pink, we can see GTV low risk, which comprises of the pelvic lymph nodes, which comprise of the common iliac, external iliac, internal iliac, obturator lymph nodes. Over here in the contouring slide, we can see organ at risk, that is rectum, which is paired while contouring. So coming to the conclusion, we conclude that bladder preservation treatment is an effective, safe, convenient option for patients presenting with muscle-invasive bladder carcinoma. Neoadjuvant chemotherapy followed by chemoradiation is well tolerated with accepted with few rates of complications. Thank you.
Any questions on the whole?
Hello, you are saying 30% you took with palliative intent. Why? Which were those patients?
So because we took patients with palliative intent because those patients had metastatic disease, they had poor GC, and they were older in age.
Actually, they had at presentation only metastatic disease.
Yes, so they presented at late stage.
Oh, then why you included them in the study?
So as to include, so as to at the time of before the presentation of before chemotherapy, we took them and we gave them we took them in our study so as to increase their quality of life.
Check your departmental data, huh? Most probably started on chemotherapy. They might have, with the radical intent, they might have progressed or have poor GC or treatment interruption. And you check your data in the
yes.
department.
You both students have collected data and you have data is the main thing which you need to assess. Data speaks for itself only. When you start assessing the data, you will see how to treat, when was the presentation, how presented and how it progressed. We all have learned from the data, from the past experiences. Thank you, Tanvi.
Morning, everyone. I'm Dr. Gazada Shamim, second year postgraduate resident in the Department of Pathology at Acharya Sri Chandra College of Medical Sciences and Hospital. My presentation is regarding a rare case reported as pelvic extraosseous Ewing sarcoma involving the uterine corpus. Starting with the general background, Ewing sarcoma constitutes a family of neoplasms that have varied neuroendocrine differentiation, and they are referred to as the Ewing sarcoma family of tumor. Ewing sarcoma lies at one end of the spectrum, which has very little or minimal endocrine differentiation, and at the other end of the spectrum, there is a primitive neuroendocrine tumor. So Ewing sarcoma is the second most common bone sarcoma in children, and the usual age of presentation is between 5 to 20 years of age. It's uncommon before 5 years and also uncommon after 20 years of age. There's a slight male predominance with male-female incidence being 1.5:1. It represents the prototypic small round cell sarcoma of the bone and is associated with a reciprocal translocation involving chromosome 11 and 22 commonly. Most of the tumors, that is 85 to 90% of the Ewing sarcoma, they show gene fusion involving two family of genes. That is the PET family, which involves the EWSR1 gene, and the other family, that is the ETS family, which involves the FLY1 gene. So the EWSR1 FLY1 fusion is seen in most of the cases of Ewing sarcoma. Now, Ewing sarcoma is thought to arise from the medullary cavity, and then it goes outwards, destroying the bony cortex and involving the soft tissue. But in some cases, the Ewing sarcoma can also arise from the soft tissue, and in that case, it is known as the extraosseous Ewing sarcoma. It's an uncommon primary tumor of the soft tissue and accounts for around 10 to 20% of the cases. The common sites include extremities, chest wall, retroperitoneum, and paravertebral space. However, its location in the female genital tract, such as in the cervix, vulva, vagina, ovary, is very uncommon, and only 50 cases have been reported till date involving the uterine corpus. Regarding the case, it was a 24-year female who presented with irregular vaginal bleeding and lower abdominal pain. She had no significant past medical history and no significant family history of concern. An ultrasound pelvis and MRI was also performed, and both suggested an intramural fibroid with cystic degeneration along the posterior and right lateral wall of uterus, measuring around 70 millimeters. This is a photograph of the ultrasonogram pelvis that was performed, showing the mass lesion with areas of cystic degeneration. So the patient was young and she wanted to preserve her fertility. So she underwent an elective myomectomy. Intraoperatively, it was found that the lesion had a somewhat ill-defined nodular and friable outer surface. The surgeon excised the mass, and fragments of the mass were received in our department. This is a gross image of the fragments of mass that were removed during surgery. And microscopy of the lesion showed small round cell tumor with cells arranging sheaths and large clusters. There were foci of necrosis and hemorrhage. And in this picture, we can see the individual tumor cells showed round to oval nuclei, fine chromatin, small nucleoli, and brisk mitosis and apoptotic bodies were also found. It was suspected that there could be a primary bone malignancy, but the bone evaluation ruled out the primary bone lesion. So further immunohistochemistry was performed, and it was found to be positive. Membrane positivity was found in CD99. Nuclear positivity showing NK X2.2 positivity, and Ki67 index was around 40 to 50%. To rule out the other malignancies, TDT and CD10 were negative, so it ruled out the lymphoma. SALL4 was negative, which ruled out the germ cell tumors, and thus we came to the diagnosis of primary Ewing sarcoma of the uterus. Patient was then subjected to adjuvant chemotherapy using 6 cycles of vincristine, doxorubicin, and cyclophosphamide. And we are following up with the patient. Just last week, she has underwent a radical hysterectomy with bilateral salpingo-oophorectomy, and the histopathology reports are still awaited. To conclude the findings, Ewing sarcoma is mainly considered as a bone and soft tissue tumor of children and young adults, but the extraosseous Ewing sarcoma is a rare subtype of Ewing sarcoma family of tumor, and the pelvic site is the least common. Clinically, abnormal vaginal bleeding is the most common presenting complaint. Some patients may, however, have enlarged uterus or a palpable pelvic mass. These findings are usually non-specific and can be found in any other type of uterine malignancy as well. Similarly, radiological features are not specific, as was in our case, because the patient was initially diagnosed as having leiomyoma. So therefore, the definite diagnosis is mainly based on pathological and immunohistochemistry findings. Histologically, the tumor is thought to show sheets of monomorphic round cells with primitive nuclei, and immunohistochemistry is typically positive for CD99, NKX 2.2, FLY1, vimentin, and in some cases, cytokeratin. And most of the diagnosis is made by the histology and the immunohistochemistry. But in cases both of these are inconclusive, we need to go for the genetic analysis, which can be done by FISH technique, that is the fluorescent in situ hybridization. And in about 80 to 95% of cases, we will find the translocation involving chromosome 11 and 22, and the fusion gene, that is EWSR1, FLY1, is seen in most of the patients. Regarding the treatment, there is no standard protocol for treatment because very few cases have been reported and the literature is very limited. However, the approach is multimodality, with the chemotherapy, surgery being the mainstay of treatment, and radiation, if needed, can be given to the patient. So to conclude, primary ring sarcoma of the uterus is extremely rare, with clinical presentation similar to the other uterine cancers, which makes the differential diagnosis difficult. The prognosis of uterine ring sarcoma is worse when compared to the benign myometrial lesions such as leiomyoma, and therefore a very careful clinical, radiological, as well as pathological assessment is required so as to make a correct diagnosis and decide the treatment strategy. And wherever there is a confusion on the histology or the immunohistochemistry, we should go for the genetic analysis. Thank you very much.
Can you show your treatment slide? How you treat the case? Have you made it? Treatment.
So actually, we refer to each the patient is in 6 cycles. So normally, with this week, doctor will give them one cycle for the and with or without the in this patient, 6 cycles have been completed, and he has recently undergone the surgery.
And normally, how many cycles you give? How many cycles you give normally? What is the age of this patient? You are sparing the fertility. You are sparing the fertility, na? Fertility sparing surgery करी है आपने myomectomy करके, and only fragments were removed.
You are a pathologist, is it? Okay. So-
Pathology.
Yeah. So I'm just, personal opinion is that when such an unusual diagnosis, I think one would send this patient for the genetic testing and not base the diagnosis entirely on histology and immunohistochemistry. Very good presentation, but it would be a good idea to do the mutation.
Thank you. Thank you, organizers. Now we complete the best paper session. Thank you.
Thanks, judges. Yeah. So now we shall begin with our next agenda of discussing genitourinary cancers. So may I invite chairpersons for the next session, Dr. Atul Sharma. He is senior consultant anesthetist at AOI Jammu. Dr. Anju Jamwal. Ma'am is heading anesthesia department, JMC Jammu. Dr. Rafiq Lahori, and Dr. Kanika Gupta. So the first lecture for the session will be presented by Dr. Sunaina Gupta. Ma'am is additional associate professor at AIIMS Jammu. She'll be discussing a talk on pain management in advanced terminally ill cancer patients.
Very good morning to everyone present here, and thanks for being here on Sunday morning. So the topic being allotted to me is pain management in advanced terminally ill cancer patient. So the objectives, can I have a hand mic? So the objective of my presentation will be definition first. What are the terminally ill patient and what is the prevalence of pain in this patient and what are the causes of pain? Then a little bit about pain assessment and WHO step ladder approach for pain management in these patients. Little bit of pain and interventional blocks and pain management in end of life care. So, according to the International Association of Hospice and Palliative Care, terminal illness is a progressive condition that has no cure and that can be reasonably expected to cause the death of a person within a foreseeable future. According to the American Cancer Society, it is an irreversible condition that in the near future will result in death or a state of permanent unconsciousness from which she is unlikely to recover. In most states, terminal illness is defined as a one in which the patient will die shortly whether or not the medical treatment is given. Various authorities, they have quoted a specific duration of 6 to 12 months, but there is no objective evidence to support this time frame. Now, this is a study in which the prevalence of pain in patient with cancer was evaluated, and it was saying the studies from 2014 to 2021 were included. Then overall prevalence of pain in cancer patient was 44%. So, and moderate to severe pain was in 31% of the patient. And pain prevalence in advanced metastatic and terminal cancer was 55%. So there was a review in 2016 also. So the pain prevalence, it has slightly decreased in our last decade. So maybe because of increased assessment of the pain and management resulted in this decline. And it was seen again in this review that an analgesic treatment was inadequate to the intensity of pain in almost 40% of cancer patients. Pain management, because it always remains secondary. First is the cancer management, treatment, chemotherapy, radiotherapy. Pain management always comes at the end. So that might be the reason for increased prevalence of pain in these patients. So if we go for the causes of pain, we all know causes of pain are neuropathic, mixed, nociceptive. So nociceptive, mixed are neuropathic. Neuropathic, we know it's central, or it is peripheral or sympathetically mediated. Nociceptive, it is either somatic or visceral. So visceral pain, it can arise from ball, cardiac or capsular, and somatic pain, it arises from bone or soft tissues. Causes of cancer pain are, it is because of the disease-related process, because of the infiltration of the cancer into the surrounding tissues, or it could be because of some compression of the nerve, it could be because of muscle spasm, lymphedema, raised intracranial pressure. So then there are other, apart from these causes, there are other causes of pain also, like treatment related, surgery, post-surgery, post-chemotherapy, or post-radiotherapy. Then debility, because of debility due to the cancer, because of the side effects also, like constipation, pressure sores, because of decreased immunity, post-herpetic neuralgia. Then other comorbidities, like the associated comorbidities, like low back pain, arthritis, angina. Now, this is a concept of total pain. And this is gaining importance nowadays in cancer pain as well as in other life-threatening illnesses also. So this total pain concept was given by Dame Cicely Saunders. So I have shown you about the physical aspect, what were the causes for the physical aspect of pain. Now, in this cancer patients, apart from the physical pain, there are other components also. So these components are social, spiritual, and psychological. Now, social, a patient who suffers with cancer, he has lost his role in the society, and he is also worried about the financial aspects. And at the same time, there may be loss of his job, worries about his future. So these are the social concerns in this patient that also contribute to the pain. And then there is psychological part or component also, like anxiety, fear of suffering, depression, and then spiritual. See, I like patient can ask you, I have never smoked in my life, so why I got the lung cancer? Okay, and I might have done something wrong. That is why God has given me this disease. So these are our spiritual components of pain. So whenever we are treating pain, apart from treating the physical pain, we need to treat these components also. So this is a concept of total pain. Now, as the pain management always starts with the assessment. So good assessment should be there, and good history taking, good examination, good imaging, this helps in a good assessment of the pain. So what we need to know is what is the type of pain, whether it is neuropathic pain, whether it is nociceptive pain, or whether is it mixed pain. Plus, at the same time, we should know what is the intensity. What is the intensity, severe, mild, moderate? What is the intensity of pain? Now, how to do the pain assessment in a cognitively intact patient, we know these are visual analog scale and numerical rating scales. In children, we use this Wong-Baker faces pain rating scale. Now, in patients who are not cognitively active, so in these patients, the assessment is done by this pain at scope scale. So in this, we see breathing, vocalization, facial expression, body language, and consolability. So if the score is 0, so there is almost no pain, and 10 is the maximum pain. Now I will discuss about the management of cancer pain with the help of WHO analgesic ladder. So this is the WHO, this is a modified WHO analgesic ladder. So we start with, in case of mild pain, we start with non-opioid analgesics plus minus adjuvants. So we start with the non-opioid analgesics. Non-opioid analgesics are paracetamol and non-steroidal anti-inflammatory drugs. The step 2 is weak opioids. Weak opioids, we have tramadol, codeine, and tapentadol. And along with it, we can continue the step 1 non-steroidal anti-inflammatory drugs. Plus minus adjuvants, we can give at the every step, we can give this. And third is after the weak opioids, we go to strong opioids. Plus then step 1 treatment can also be added. And step 4 is the interventional treatment along with this strong opioids and adjuvants. Non-opioids, as I have already said, these are the paracetamol and non-steroidal anti-inflammatory drugs. Weak opioids are tramadol, codeine, tapentadol. Strong opioids, most commonly used morphine, fentanyl, buprenorphine. Then adjuvants, we have antidepressants. We are using amitriptyline, duloxetine, anticonvulsants like pregabalin, gabapentin, then muscle relaxant, anxiolytics. So these adjuvants can be used at any stage, any step, whether it is step 1, whether it is step 2, whether it is step 3. Now, after assessment of the pain, the step necessary for the given intensity. Suppose it is moderate to severe pain. So it is not always necessary that you go to step 2 only and then you go to step 3. You can always start from the step 3 and then you come down the ladder. Second thing is, do not give 2 drugs from the same step. Like 2 non-steroidal anti-inflammatory drugs should not be combined, or 2 opioids should not be combined. And once the patient is started on this analgesic ladder, it is very important that you review regularly to titrate for the exact dose. Now, this was a study in which they assess the safety and efficiency of omitting step 2. Like there are 3 steps, 4 steps in, you can omit the step 2 and directly go to step 3. So what they have seen is that like there was a control group with paracetamol plus weak opioid up to the maximal dose. And second group was paracetamol plus strong opioid. So in the control group, 53% of the patient, they needed to go to a stronger opioid because of the ineffective analgesia. So what they have suggested that we can go directly into the step 3 with low doses of strong opioid rather than going for high doses of a weak opioid, because 50% of the patient almost they go into the step 3. Now, principles of pain management, aim is prompt treatment of pain and to prevent its recurrence and achieve realistic goals of pain relief. Again, we all know that whatever analgesic we are giving, it should be by the mouth because it is simple, effective, convenient, can be taken at home, by the clock for continuous pain relief, by the ladder because stronger analgesic for increasing pain is a principle, by the individual according, it should always be individualized, and adjuvant drugs, they can be added to any step. Little bit about morphine. Morphine has always been the gold standard for treating moderate to severe pain. And it is not when the pain intensity is severe in terminal illness, only we give morphine. We can give morphine whenever the pain is severe. Whenever the patient experiences severe pain, even if it is the stage 1 of the cancer, stage 2 of the cancer, we should start with the morphine. Now, dose is 5 to 10 milligram 4 hourly, and we can increase the dose by 50%. That 4 hourly dose increased by 50% till a good analgesia is achieved. And there is no standard dose. Dose is increased to the point at which pain is controlled with tolerable side effects. Now, there are some side effects of morphine also we should know, that it causes constipation and it stays till the patient takes morphine. So we should always give a laxative, that is a stimulant laxative along with this opioid. And then opioid-induced nausea, vomiting, it is also very common, but after 1 week it wears off. Then pruritus, but most common are constipation, nausea, vomiting. So we should treat this whenever we are giving morphine. This is the overview of all the few Cochrane reviews of opioids for cancer pain. And it was seen that almost 90% of the patient, they have a meaningful pain relief from oral morphine or fentanyl patch within 10 to 14 days. So, and 77% of the patient report at least one side effect, either it is constipation or it is nausea, and 10 to 20% of the patient needs to change to some other type of treatment. Now, barriers, there are many barriers to adequate pain management in cancer patients. The barriers of like clinician barrier, we have lack of pain management specialist, then reluctance to prescribe opioids. Why most of the clinicians, they are reluctant in prescribing opioids. That is because of the restrictory concerns that are associated with opioids, because we need to have a license, we need to have a proper storage of these drugs and proper dispensing, need to maintain the records. So all these factors, most of the clinicians, they are reluctant in prescribing it. And then again, adequate provider knowledge regarding pain management. Then patient barrier is patient is hesitate to report pain. Patient finds that like he's having a cancer, he or she is having a cancer, so he has to tolerate that pain. So that thing, they don't report the pain. Then second is like whenever you start with morphine, the patient thinks that now he is going to die because it is a terminal stage now and it's going to die. So that is also one of the factors. Now, again, I said like use of WHO analgesic ladder retains pain relief in about 80 to 90% of the patient. Now, if pain is not controlled with adequate dose of morphine, we should review the cause of the pain. Maybe it is neuropathic pain, and morphine may not help in certain types of pain. So these are the pains like bone pain or visceral pain where morphine sometimes may not be helpful. And then you go for unresolved psychological and spiritual issue. Now, the pain that is not controlled by morphine or is producing distressing side effects of morphine, that this patient may benefit from an interventional approach at all the steps of the WHO analgesic letter. So interventional approach can be applied at all the steps. It is not after step 3 only we have to go for the interventional approach. So it can be applied at any step whenever the pain is not being properly controlled or whenever there are a lot of side effects of the morphine. So few interventional procedure, these are neuraxial analgesia, then sympathetic block, peripheral nerve blocks, and some minimally invasive procedure. The successful use of this technique depends on the selection of the right therapy for the right patient. Now, neuraxial analgesia like epidural therapy, we can put epidural along with morphine, and we can connect it to the catheter with PCA pump. So this is done with patients with shorter life expectancy. With patient with slightly more than 3 months life expectancy, what we can do is we can intrathecal drug delivery devices, they are given. So this is we have implanted the intrathecal catheter just near the substantia gelatinisa, just near from where the pain is being originated. And then there is a subcutaneous pump. So, but this is reserved for patients who have more than 3 month life expectancy. Spinal neurolysis in the terminally ill patient. We inject like 0.2 to 0.3 ml of the drug to the specific nerve roots. We target the specific nerve roots, and this is very easy to perform. This is a study regarding the in pancreatic cancer related pain, and what they have proposed that a wider application of intrathecal analgesia in cancer pain treatment to ensure comfort at the end of life. So a wider intrathecal analgesia has been proposed. Celiac plexus block, these are the sympathetic block. So celiac plexus block is the most commonly done procedure in carcinomas. Like this is mostly done for carcinoma pancreas, and it has got a high grade of recommendation for carcinoma pancreas. So then superior hypogastric plexus block, this is done for pelvic malignancies. Again, this is also sympathetic block. Ganglion impaired block is for perineal malignancies. Then we can go for peripheral nerve blocks also. We can just block the nerve which is causing pain. So paravertebral blocks in the hand region, brachial plexus block, or intercostal block. So here we are not giving phenol or alcohol. Here what we are giving is local anesthetic only. Specialized some intervention like cordotomy. In this is done by a neurosurgeon. So what they do, they provoke lesion to the spinothalamic tract, thus blocking the pain pathway. Okay, so this is short-term survival of the patient, which the patient who have short-term survival, and they suffer from severe neuropathic or nociceptive pain. Then we have percutaneous ablation of metastasis. So it can be done by radiofrequency or cryotherapy. It's good for metastatic bone lesions. Vertebroplasty, management of vertebral instability and spinal cord compression. So cement, we inject the cement under radioscopic guidance, and it provides a very good relief. But again, we need a skilled person to do all these blocks. This botulinum toxin can be given, it is given locally to reduce the neuropathic pain and muscle spasm. Then psychological support and non-pharmacological therapies. So the final days of a patient who is terminally ill. So pharmacological management should follow the WHO pain ladder in combination with early adjuvant therapy and interventional therapies. Whichever interventional therapy is decided for that patient, we should go for it. And the second thing is at the very end of life, comfort is the priority. So the daily requirement of opioid is calculated and converted to a subcutaneous dose, and it is given over 24 hours in a syringe diver, and continuous subcutaneous infusions are given. So these are the subcutaneous infusions that are given. Like if we have calculated a dose of morphine, so half of the dose calculated 24-hour dose we can give subcutaneously to the patient. Other drugs that can be given subcutaneously, ondansetron can also be given, midazolam can also be given. Then we have transdermal fentanyl patches. So all these can be given in a patient who is terminally ill. Now, pain at the end of life is a multi-dimensional experience, and it requires an integrated approach. So apart from treating the physical aspect of pain, we should try to treat the pain as a whole, along with the psychological and spiritual component also. And depression and anxiety are common in advanced cancer, and pain threshold may be reduced if they are not adequately treated. So what should be the goal? The goal should be to improve the patient's quality of life, not to increase the lifespan at the expense of its quality. So it is a multidisciplinary approach always. Pain management in this critically ill patient. It requires a palliative care physician. It requires a pain medicine specialist, oncologist, neurosurgery, neurosurgeon, orthopedics, social care worker, then a person, psychological, supporter, primary care, and a very good specialized nursing. So thank you.
Thank you, ma'am. Questions, if any, from the chairperson? Meenu, ma'am.
Thank you, Sunana. It was a very nice talk.
Thank you, ma'am.
Now, any questions from the house?
Yeah,
Thank
Bindu,
you,
ma'am.
Dr. Sunana, very nicely presented.
Thank you.
And just for the some students, PGs and others, no, pain is actually the fifth vital sign. In our record, hospital record, we saw the nursing, they are actually monitoring pulse, BP, temperature and all
Yeah, it's
that.
the fifth vital
And now
sign,
it is the guidelines also, and pain, we have to monitor pain also daily. The charts you have shown for the all the students. We know our students also everywhere. The charts should not be kept in the file, but they have to be properly filled once you are visiting your wards or you are seeing your patient. The pain is the fifth vital sign.
So
that
you have
is-
included it in the charts.
Definitely,
okay.
I know your institution and all that, and make it a practice even in the routine OPD cards also,
That's good.
where all those facial signs and pain score in the new whatever the management they are going to, because this is the amendment phase of our own country.
Yes, yes.
Western already they have included in their routine communication OPDs and all that. You have to spend time with the patient. That is one thing, because we are loaded with a lot of patient. I know it is difficult, but it is mandatory, most of the institutions.
That's good, ma'am.
Next, you have shown the study of omitting the step 2
Yeah.
of ladder. That is definitely required most of the patient.
Yes,
Again, the
yes.
problem of our country, availability of morphine and drug acts, and we know there we have to issue because of storage problem and whatever is there. Still, morphine is a better, but only the laws and act and everywhere.
Yes,
there is-
we should know how to give morphine. And the second thing is most of the people we are hesitant because storing
other
is a
issues,
problem.
other issues
Yeah,
also,
so many,
and that
license is required and all.
very nicely presented.
Thank you, ma'am. Thank you so much.
One small comment I want to make as a practicing oncologist. Pain management should not be, left till at the last, at the fag end. It should be upfront in the management of the cancer patients. So what I have started in the last 2-3 years, whenever patient is referred to us for, initial diagnosis of suppose bony metastasis. So already he's taking Ultraset. So whenever they come to our OPD, they are in so much of pain. So I have changed my practice actually. So I start them on morphine. The next day, the patients are far better. We tell them that it's a brief course because initial workup will take 7 to 10 days, maybe 15 days. So compliance is better. The patient's quality of life is better. They trust us as an oncologist, and the dropout rate has, significantly gone down because patient says, "Meri pain to relief hui nahi, what are you doing?" So whatever form of therapy we start, be it radiotherapy or chemotherapy, it will take time to act. So pain management should not be left at the last. It should be upfront. It should be the part of the treatment. Yeah, thank you. Sir has a question.
That was a very comprehensive presentation, ma'am, on your part. I would like to add that, like you mentioned, that whenever the word cancer is attached to pain, so pain has a very different meaning altogether. So it is a multidimensional, it has multidimensional aspect to it. It is not just the physical pain, but it is also spiritual component, like you mentioned, it is there. So whenever we're talking about the terminal illness, so these patients, they might not be able to communicate also. So the pain assessment becomes difficult when we're dealing with those patients. So we have to have a very high index of suspicion. For example, that we have to look for the non-verbal signs such as grimacing or, guarding in such patients. So as to have, just to make sure that even if they're not able to communicate, we have to treat the pain. That doesn't mean that they don't have pain. Also, the oral route might not be available in such patients. The patients might not be able to swallow when they're, bedridden or they're in the terminal stages. So we have to look for other routes like transdermal routes or subcutaneous routes of administration of such drugs. And like you mentioned, ma'am, the interventions. So interventions, they are said that it should not be the fourth step, but it should be the side rail of the ladder. That is at any point that if we feel that the patient is having intractable pain, refractory to drugs, or is not able to tolerate the side effects of morphine. So then we have to give interventions to those patients.
Should be combined at any step, we can combine that.
Yes, ma'am.
But only we need a skilled person to do those interventions. So,
Ma'am, excellent presentation.
Thank
I just want to know, in our setup, what is the best treatment for domiciliary treatment?
domiciliary, it's oral morphine only.
Low dose,
Because
low dose, 5 milligram, 10.
when the patient comes first with the 5 milligram, that is the
Yeah.
lowest dose we start. This 5 milligram is 4 hourly we start. Now, if the patient is not getting any relief, so what we do this from 5 to 7.5, like we 50% increase in this. So we slowly keep on increasing, looking for the side effects until the patient achieve a good analysis. So at home, it is the best. And in case of the patient who are terminally ill, so who cannot take oral morphine, so what we do, we put them on subcutaneous doses. Either we can give intermittent subcutaneous doses or subcutaneous infusion.
Ma'am, my question is actually in our setup, how we can get the morphine?
A morphine, yes, that is what
That
I
is
was
the biggest
saying.
question.
You can get it from GMC Jammu and like in Gandhinagar Hospital also.
I am in GMC Jammu also, even as
So
a consultant.
I think ma'am, your ma'am is heading the palliative.
That's why I,
Having abundance of,
No, I think,
that's why I asked the question. Because a lot of cancer patients come to us and we are in really dire states.
yeah.
We are not giving naproxen or something like that. That is a
That doesn't.
That
morphine. I know it's very difficult to get.
I think
Because
ma'am, it's easy to get now because they are.
in our setup, it is quite easy.
Okay, ma'am. Next time I'll send it to you on.
But if the patient is unable to swallow, then you can go for transdermal fentanyl patch.
Yeah.
That is
Okay, ma'am.
also-
Thank you.
Right, Nazir sir. Go ahead.
Thank you. This was an excellent talk for management of pain, but this is a theoretical because we talk of step ladder and WHO and other things and the pattern or how to manage these things. Practically, if we see, it is absolutely different because when a patient comes to a specialist, I mean, I'm a radiation oncologist. When patient comes to me, he has almost taken, they have started from step 3 only because the patient, when gets diagnosed, he goes to the local doctor, then to the surgeon and then medical oncologist. Finally, when they fail in managing the pain, and then they refer to the pain palliative specialist or a radiation oncologist because for radiation managing of the pain. That time only they have already exhausted all the analgesics, whatever are available. I mean, I have a patient in ward even this time. Most of the beds are occupied by just for pain management who have already received these codeines, tramadols, and even morphine. 10 milligrams they give schedule BD, sometimes TD, 40 milligrams bedtime. This is basically in clinical practice what is going on. So in such situations, what I wanted to say, a patient comes to me who has received these all things and is on morphine, say 10 milligrams TID like this thing. Should we increase the dose or should we start from step 3 onwards? Because interventional is not whatever, I don't know, this anesthesists will agree with me on. These blocks are not always possible because I have sent many times block to the anesthetist, kindly do in this patient block. They are saying this is a stage 4 disease, poor performance status, and he may not respond because he may respond to this site and the pain will be having at the different site. So the pattern of pains are different. So such are the situations basically which practically we are supposed to handle.
Situation phase. So first of all, what there should be awareness that like pain can be managed. So patient should know if pain, it is not like the cancer pain is there, it cannot be managed. The thing is there should be awareness on the part of patient also. Second thing is when a when anyone starts the morphine, then it has to be properly monitored because we need to give a proper dose at proper time. See, I have already shown you the slide by the mouth, by the ledger, and according time. So time is very, very important. If like morphine dose is being missed, and if the dose is not proper, good analgesia will not be maintained. So that is one thing, that proper dosing should be there. And the third thing is it is whenever a pain patient comes to a specialist, we should assess what is the severity of pain, and we can start from the step 3 also. It is not that we have to go up the step. And if the patient is already taking morphine, as you said, so you have to assess whether the patient is taking proper dose of the morphine again. Is there any mechanism to take care of the breakthrough pain and all these things?
So time for the
Thank
next
you.
session, I think.
I request chairpersons to stay back. Dr. Rohit Lahori has come. Sir, please come on the dais as chairperson. So next is there will be lecture come panel discussion. So it will be presented by Dr. Shwet. He's the interventional radiologist. Please come on the dais. So he'll be speaking on interventional radiology in oncology patients. And this session is sponsored by Hexamed Diagnostics. Like I have to move the slide myself. Okay. So may I invite the panelists for also Dr. Gitanjali ma'am, Dr. Nitin Vermani, Dr. Ishan Gupta, Dr. Anshita. Okay, I'll try to finish in 20 minutes. Very good morning and warm welcome to the chairpersons, to senior radiologists in the panel, and to all the delegates present in this oncology conference. I'm Dr. Shwet Sharma. I'm a lecturer radiodiagnostist at Government Medical College, Jammu, and a visiting consultant at Hexamed Diagnostics. First of all, as a radiologist, I'm very delighted to be a part of this oncology conference, and I would like to express my gratefulness and thank you to the organizing team for inviting me as a moderator in this panel discussion. Many of my oncology colleagues might be wondering the role of intervention radiologist in oncology patient, or the need for introduction of this lecture in an oncology conference. So to highlight the importance of intervention radiology in oncology patient, I'll give a brief description about this subspecialty, and then we will take you to few clinical case scenarios wherein the role of intervention radiologist and these minimally invasive procedures has been very profound in the management of terminally ill cancer patients and in improving their quality of life and reducing their morbidity and mortality. So the role of intervention oncology has become so integral for supporting patients with cancer that many consider it as the fourth pillar of oncology, a recent addition to the traditional 3 pillars of surgical oncology, medical oncology, and radiation oncology. So now we have a interventional oncology. So what are the various procedures we do in intervention radiology or intervention oncology? They are grouped into 2 main groups. They are vascular, which are done in cath lab under DSA guidance, or non-vascular, which we do under USG, CT, fluoro, or MR guidance. So what are the various vascular procedures we do in oncology patients? So they can be venous procedures like placement of PICC lines, peripherally inserted central catheters, and then chemoport insertion, very commonly used in cancer patients. Then other venous procedure which might be required in oncology patients are like dialysis fistuloplasty, central venoplasty, then thrombolysis, IVC filter placement. And there are arterial procedures which are very commonly done in cancer patients, like in liver cancer patients, we do for palliation, TACE and tear, and then pre-op embolization of tumor bed before the operation to reduce the risk of bleeding and to minimize the risk of surgery. Then other operative procedures which might be needed in oncology patients are like pre-operative or like vascular bleed embolization. If a tumor like erodes into the artery and there is torrential bleed, we can do like coil embolization. It is a minimally invasive procedure. We can go intra-arterially and do coil embolization of that bleeding vessel and to stop the bleeding. Then what are the various non-vascular procedures? They are more commonly done as compared to the vascular procedure in our state.
but both vascular and non-vascular state procedures are done very commonly outside the state. So what are the various non-vascular procedures we do? Like we have grouped together them in various systems. Like in biliary system, first is the PTBD, percutaneous biliary drainage. I'll take you to the case scenarios of each one of these so that you can understand the importance of these minimally invasive procedures in oncology patients. Then it is cholecystostomy, like tube insertion into the gallbladder in case of acute cholecystitis. Then urological procedures like percutaneous nephrostomy, DJ stenting. Whenever urology people or uro-oncology people, they are not able to stent the ureter or the obstructed urosystem by the retrograde stenting. Most of the time they need the help of intervention radiologists to do the antegrade stenting in case of obstructed kidneys. Then there is gastric procedures like percutaneous gastrostomy, NG tube, NJ tube. You can easily put the nasogastric tube, but in cases of esophageal carcinomas like oral cancers, these patients require like image guided insertion of NJ tube. Like in case of antral carcinoma, we need the tube to be placed distal to the site of obstruction to feed, because feeding is important. Otherwise, the patient get loss in weight and etc. And also we can do percutaneous gastrostomy and percutaneous jejunostomy, which are minimally invasive procedures as compared to the surgical gastrostomies and jejunostomies. Then all type of biopsies, they are very basic biopsies from any like malignancy, be it lung carcinoma, renal carcinoma, or any malignancy or soft tissue. We can take the sampling using image guidance of ultrasound or CT. Then pain palliation, ma'am was the previous talk was about pain palliation. And one point ma'am said, only thing is the person doing it should be having well expertise. So you can always take the help of an intervention radiologist just to locate the site of nerve block, because we can help you to easily locate the plexus in the small nerve blocks. We can do that. Then drainage procedures very commonly done, pleural, site, any collection, abscess drainage. Then ablation procedures like RF and microwave ablation or chemical ablation. There are curative treatments in many small tumors like in stage 0 or stage A, B, liver HCC, small RCCs, in thyroid cyst ablations. So now we'll go to the case scenarios and discuss with our panelists. So first case, as you see, this was a gentleman, 45 years old, who was operated for sigmoid carcinoma. He was disease-free and for 1 year follow-up. And after 1 year, he came to us with multiple nodules scattered in both the lobes of lung. But the nodules were very small. They were less than 1 centimeter. Only this one lower lobe nodule was like 19 mm. So we had to start some treatment. First, we had to diagnose what are these nodules. So for sampling in these, in cases of small nodules in lung cancer, I'd like to ask Dr. Ishan, who is he's thoracic fellow, he's done his fellowship in thoracic radiology. So what is your experience about sampling these small lung nodules?
Hi, Shwet. So small nodules, they are challenging, especially in the low lobes. So like this was one case in which we had tried to place the needle into the nodule, as we can see in the subsequent slide, I think.
Yes.
So when we placed the needles, the nodule had completely moved out of the plane due to breathing, and subsequently we had to redirect the needle, as you can show.
So you can see there are two slides. One needle is there. So when we were planning the biopsy in the superficial skin needle, the lesion was inside. But when we entered into the lung, the lesion was completely gone. It was in the few cranial sections. We missed the lesion completely. This is a normal thing with the lower lobe lesion, because the patient inspires and expires, the lesion moves, and 1 to 2 centimeter lung moves up and down. And if the lesion size is small, you ought to miss. Many a time you ought to miss the trajectory. And once you are in the lung, you have to manage the needle within the lung. You cannot just come back and then puncture the pleura again. There is risk of pneumothorax. So that is what we did here. We managed to push the needle up to the nodule, and it was very difficult. It was a difficult case and a learning case for us. But finally, we were able to. If you will see this sagittal section slide, where the trajectory, the insertion point was way below, and then the lesion was up. Then this is a normal thing with the lower lobe lung lesions. But we managed to project the needle up to the lesion, and we took the samples 1 centimeter core.
Yeah. So obviously there are risks, like there was alveolar hemorrhage in this. There are risks of pneumothorax that can occur with more passes if we take, and there's risk of hemoptysis also. But luckily, nothing significant happened in this patient, and So it was a good learning case for us.
Managed. It was a learning case. My point of including this case here, it was that if the lesion is large, it is abutting the pleural surface, we can easily do that biopsy. That is not an issue. But the thing comes when the lesion is small, it is intraparenchymal, surrounded by lung on all sides. Then we have to go inside the lung. The risk will increase. The risk of pneumothorax, the risk of hemoptysis, it will increase, but that will not stop us from taking biopsy, because if you have to take sample, you have to take the risk. And we took the risk. Fortunately, there was little hemoptysis, which was controlled with the Trenexa injection. Otherwise, had there been, pneumothorax, we can anytime put a pigtail into it.
And sir, what was the result? It was metastatic?
It came out to be positive for adenocarcinoma. Unfortunately, it was positive for adenocarcinoma, and patient was started on palliative chemotherapy. So this is the second case, a biliary case, very common biliary malignancies, cholangiocarcinomas, then GB carcinomas, which are invading the hyla and obstructing the biliary drainage. Like if the primary confluence is gone, the bile is not draining, it is pus everywhere in the biliary system, because ascending cholangitis will set in days. And believe me, it is very deadly complex. My clinical colleagues will agree with me that ascending cholangitis will it is a life-threatening condition. It will take the toll. Like only counts we have seen in ascending cholangitis, they are like in 30,000, 40,000s. After leukemia, this is one condition where we see this high septicemia and count and patient goes. So we need to drain this pus, which is actually bile, infected bile. So we need to drain. But my gastroendoscopy colleagues will agree with me that most of the time they face difficulty in going up, because they have to take a complete U-turn from the papilla up into the hyla. So more easier procedure is that we do PTBD. This was a 46-year-old male which was a known case of carcinoma GB with periportal lymphadenopathy and complete obstruction dilated system. He presented with ascending cholangitis, raised serum bilirubin. The problem with bilirubin is septicemia is one part. The second thing is you cannot give chemotherapy, you cannot do palliation, and you cannot give chemotherapy because it is hepatotoxic also, and cholangitis has already set in. So the only thing we can do to help patient or palliation is PTBD, which we have been doing it. Not here in Jammu. We hope to do it here soon, but we have done these PTBDs. And this is one case where we punctured the left duct, then passed the wire distal to the obstruction site and inserted this catheter. So we were able to remove the obstruction, because in malignant obstructions you have two options. Either you can stent it, the site of obstruction metallic stent, or you can pass the catheter, which is drainage, like RBC, ring biliary catheter we call it. It has holes proximal to the obstruction, it has holes distal to the obstruction. So bile will flow with cholangitis and it will palliate this is a good palliative therapy for cancer patients. So our follow-up, fever normalized in 2 days, bilirubin was 2.1 and patient was started on palliative chemotherapy. So this is the other urological example. Like very commonly you see carcinoma cervix patient, advanced stage carcinoma cervix, infiltration of both ureters and bilateral hydronephrosis. This one patient also presented with uremic encephalopathy due to that bilateral ureteric obstruction, and then urine outputs were decreased. What we did PCN, percutaneous nephrostomy. My urology colleague also commonly do this PCN procedure, but they do it under fluoro guidance. But the more, if you use ultrasound for the puncture, it is more safe and less associated with less morbidity for the patient. So we did this PCN and put the DJ stent on left side and right side. After 5 days, his encephalopathy was gone and creatinine was normal. He was posted for pelvic exentration. So again, one more example of gastric. This was a case of buccopharyngeal carcinoma who was presented with absolute dysphagia since 4 days. So anywhere carcinoma, if there is along the oropharyngeal tract, like carcinoma, oral cavity, buccal, tonsillar, pharyngeal, or esophageal carcinoma, patient will be having difficulty in feeding. So in that case, you can always do percutaneous gastrostomy, percutaneous jejunostomy to feed the patients. So these are all minimally invasive procedures. Routinely, we can do it. We can do it here. So this was the patient we put in a gastrostomy. You can see the CT image, sagittal, and the clinical picture also. So after follow-up, after 1 month, weight increased and mid-upper arm circumference increased by 1.2 centimeter. The pain management, ma'am has previously explained very well the various procedure we do to alleviate the pain of patient. This was one pancreatic carcinoma are very frequently known to invade the celiac plexus and results in excruciating pain and debilitating condition of the pancreatic carcinoma patients. So this was one case we did CT guided celiac plexus block. Like ma'am was talking about the guidance, this is the CT guidance we take. We just have to pass our needle anterior to the celiac artery origin. This is where the celiac plexus ganglion usually lies. So we pass it needle anterolateral to the celiac artery origin by avoiding any arterial puncture. It is a very demanding procedure. And then we can inject the neurolytic agent and the local anesthetic. Neurolytic agent used is the alcohol or phenol, and the local anesthetic long-acting bupivacaine, we use it. Only after making sure that the needle is not into the arterial system and there is free flow of contrast. Then later we also inject 5 ml saline to flush the needles and then remove the needle. And in this case, the VAS score immediately post-procedure reduced from 7 to 3. So, but the only thing is we should offer these treatment modalities to cancer patient early in the disease course, because later, if you offer later, there is not much improvement in the pain due to the sensitivity of system. So the earlier we start, the better it is. So with these clinical scenarios, I end my discussion and would like to ask my senior colleagues what is their experience about these intervention procedures in here in this state in Jammu.
Dr. Shwet, it was an excellent presentation, very informative. So apart from the diagnostic and palliative aspects of intervention radiology, which is well illustrated by these case examples, there is a therapeutic aspect also, like the image-guided thermal
RFA.
ablation procedure, like RFA and microwave. They are increasingly finding a role in the cure of many cancers. Like most of the treatment guidelines, they have and algorithms, they have incorporated microwave and RF ablation as a treatment modality for the early HCC, like BCLC stage 0 and A stage HCCs, and not just HCC, it's the intrahepatic cholangiocarcinoma, limited metastatic disease in liver, then early RCC, and even some so many other malignancies. Like, so they are finding an increasing role. So, like as an intervention oncology, this branch is definitely moving forward. And as you very well pointed out, it's not the fourth pillar of cancer care.
Sure.
So that's
So one more point. I have not included in the slide, but the osteoid osteoma, very common bone tumor, bone cancer, and a very easy CT guided. We can do RFA. We just need to pass the needle into the tumor, and then we can ablate it with RFA. Like other tumors, Dr. Nishin Varmani has told, oligometastatic disease. Good.
Thank you, Shwet. You've told everybody that we are now one of their pillars. So every conference you'll have to call us now.
Yeah.
So also, like you mentioned in celiac plexus block. So we as pain physicians, I would just like to add that we also use, we're doing it routinely under ultrasound guidance also nowadays. Because why put a patient to so much exposure of CT when you can avoid that exposure. So ultrasound, I think, is one modality which can be explored for celiac plexus block.
We did the procedure on CT guidance, but yes, you can take any. The point is to place the needle at the right point to block
Definitely, sir. But with CT, the thing is that so much radiation exposure is there, but so that can be avoided with ultrasound.
About radiation, I'd like to add that there is a misconception about radiation actually, because radiation injury or radiation risk, whatever we have accumulated from that atomic bomb exposure, like nuclear. It increases the risk of cancer. But if you take a case of a carcinoma pancreas, say carcinoma pancreatic patient, he is having the life expectancy is too short for us to not put him on CT. We frequently do CT scans because the risk from the CT scan is.
So I think if it is needed rightly, it should be done. But if can be avoided, then better
to go for non-radiation.
Because it is not just for the patient, but also for us as physicians to have.
Take-home message is that if the patient is young, we prefer the non-radiation modality.
Definitely.
But the patient is old and is having a less life expectancy, then he will benefit from the procedure.
From the procedure, definitely. And also if the celiac plexus is being invaded, that I think ultrasound, it is not.
Ultrasound is always better. If you can do it, it is always better.
Actually, maybe more confidence levels with CT. Because and in case we have CT fluoroscopy, then there's nothing like it. Even those small lung nodules are better sought after. And then nowadays, with all these necrotic collections that occur with all carcinomas, we try to do the pigtail drainages, which is another therapeutic modality of reducing all the pus load or reducing all the necrotic load of a tumor. And then onwards, the treatment modalities can follow, and they are more effective after that. So many times I've seen Satyankar or any of these medical oncologists, they come up and say you have to reduce the fluid so that the third space doesn't take up the chemo. Unless and until we reduce the third space fluids, the chemo will not act. So our role is prior to them, and they cannot treat if we don't intervene at the right time. And opening up a patient is the last thing that a clinician wants, because already they're very sick and the risk of losing them will be more with any surgery.
One point I would just like to add up here is when we are doing these interventional pain procedures, particularly I'm talking about the celiac plexus. Very important thing is you need to know the evidence of the procedure. The evidence of the procedure is 2A. So 2A is a very good strong evidence regarding the pain management about the celiac plexus. Number 2 is a right procedure by a right person at a right time. That's the most important thing. Because why we want to take this person earlier in the modality to celiac plexus is whether that is an ultrasound guided, you do it under CT guided, you do under fluoroscopy guided. The important thing is, when should we take this patient? In the later stages, we have the complication, we have the ascites, we have a lot many things. Like you cannot, it's very difficult to do these procedures under ultrasound guidance. Once the ascites is developed, once the disease is pulmonary. So it's very important. And if you see the guidelines, the latest guidelines that are coming right now, there's a rising trend in interventional pain management, rising trend in interventional pain management in cancer pain management, A lot of publications have been coming up in this context. So the important thing is a right intervention that has to be done, whether you do it under CT guidance, whether you do it ultrasound guidance, whether you do it under fluoroscopy. Well, if we take about the evidences of all these three, there is a very simple difference between all these three procedures, whether you do it in any of the modalities.
The modality you are comfortable doing.
The most important thing is when you do it. So if you do it earlier, what you are going to do is you're going to get benefited by one more thing. You are going to decrease the burden of an opioid over it.
Yes,
Okay.
exactly.
So opioid consumption is going to be less. That is a very important thing, because I have been seeing people saying that I'm being given the opioid about 300 milligram per day. Well, that 300 milligram do come with the complications. They don't come without complications. So to reduce the complications, and it is basically when we were talking about earlier, we were only talking about the three steps. That is World Health Organization 3 steps. Step 1, step 2, step 3. And we have already kept the intervention on step 4. Now I say that the modality has changed. The intervention is a bidirectional. It's a bidirectional. It can come, it's not basically step 4. It is a step 3. It can be a 3. It can be a 2 at 1. It's a bidirectional. If a patient comes in with an agonizing pain, or you want to decrease the burden of the disease also, you want to improve him socially, spiritually, morally, behaviorally, physically, then you can plan about for an intervention. I think the intervention is wonderful. I find the role of interventionist radiologist, if they are doing it, this is wonderful, particularly in the early stages. Thank you.
Thank you. Thank you for such nice words. But I would like to ask my clinical colleagues to give us more chance to help oncology patients elevate their and improve their quality of life. Like we can help them in many ways. You can always reach out to us and ask us, is there anything you can do to improve the quality of life of oncology patient? So this was the main reason why I chose this topic, like intervention radiology in oncology patient.
I like to add a thing. It is always a multidisciplinary team
Yes,
that
exactly.
will help in.
Yes, exactly. It is.
So it is not either radiologist or a pain physician, oncologist. So it is.
We take the privilege of calling it as intervention radiology because primary person involved in this is radiologist, but we always need clinical persons, anesthetists like pain block, we need anesthetists. If there is drainage, we need
better management.
It is a multidisciplinary approach actually.
Thank you. Thanks, Dr. Shwet. So the next topic will be a panel discussion on metastatic RCC to be moderated by Dr. Amit Sherawat, He's come from AIMS Rishikesh. Thanks, panelists. The chairpersons need to stay back. Adu sir, you can't go. So Amit, please come. So the panelists for the next session, Dr. Sushil Jain. He's a robotic surgeon at Fortis Gurgaon. Dr. Sumit Pandita. He's a radiation oncologist at AY Jammu. Dr. Rajpal Singh. He's a radiation oncologist, senior radiation oncologist at SMBD Narayana. Dr. Lalit, he's come from Jaipur. I think it's Manipal Hospital. Okay, please come. And Dr. Anuja, ma'am is a consultant at its comms and a visiting faculty at Hexamet. Dr. Sindhu Sharma, ma'am is also a senior consultant. Okay, Amit, take over. Ma'am is here at I would request Dr. Satyankar sir also to join the panel. And with permission of chairpersons, I would like to involve audience if anyone want to participate in panel discussion. Thank you. So over the next 15 to 20 minutes, because since we are already running late, we are going to have an overview of metastatic RCC in 2023. And the main idea is to get inputs how you are managing in your day-to-day practice. It's not about one-way didactic thing. So I am going to take inputs how you are managing, how you are contributing to the RCC. So this was supposed to be the original panel, but since we are having one or two who are missing, so we have joined by Dr. Sushil, who is a surgeon. So his case is a 60-year-old female. She presented with history of pain right lumbar region since 6 months with no comorbidities, good performance score, no issue weight loss, hematuria. So the single isolated symptom was just vague pain. For that, patient was evaluated by a physician. He advised ultrasound showed the renal mass with typical history, and then CT scan was also advised by local physician. So we will start with how we proceed with such patients. So we will start with our medical oncology colleague, Dr. Lalit. So if such patient comes to your practice, how do you proceed further?
Now that we know that this is a large mass involving major, almost two large part of the kidney, we would like to do the metastatic workup. And for the metastatic workup, at our center, we rely more on PET-CT because it will give you not only the idea of the local invasion and all, but also the metastatic setting. And
so since patient is having already contrast CT scan, still you would like to get a PET-CT to get more clarity on metastatic work. Any difference of opinion? Anyone want to add something? Dr. Sushil, like as a surgeon, that patient is coming to you on CT scan, there is just renal mass.
Yeah, if still CT scan is there, I would like to do PET scan. Okay, earlier days, chest, CT chest and bone scan, but nowadays we are going for single imaging, that is PET scan. So
okay, so actually that's the difference between practice and whatever guideline we are. Usually, most of the guidelines they ask to refrain from offering PET-CT to such, because that is not going to add to any additional information. So whatever treatment we are planning, that treatment plan can be well done with just contrast CT scan and bone and brain imaging. Yes, Dr. Satyankar. You want
I
to
totally agree with you. Just in case the CT is, creating, it's not like non-diagnostic or some kind of confusion, like some, non-enhancing lesions in the lung or some kind of confusion. So PET maybe, additional may have an additional role. Otherwise, CT is good enough.
Radiation colleague, like if there is a suspected case of doubtful oligometastatic disease, so that is a major concern in such patients. If limited disease burden, oligometastatic on CT scan. So is PET-CT is going to change your treatment plan in that case?
And definitely PET is going to change the treatment plan. PET can detect the mets which are not detected on CT scan. We can detect small mets on the PET scan. That will definitely change the treatment plan.
Right.
So in select group, the patient PET CT can change the treatment plan, but by default, if there is metastatic disease on contrast CT scan or non-metastatic on contrast CT scan, so clearly PET CT will not add to anything. And coming to the brain imaging, what you are doing in your clinical practice, anyone can take this. Are you routinely doing brain imaging or bone imaging for that matter for RCC patient, suspected RCC patient on radiology only?
Well, in case the patient is not symptomatic from the CNS point of view, especially if I have done a PET scan and there are no straightforward lesions over there, I won't go for an MRI on a routine basis, but in case the patient is symptomatic, definitely I like to do a scan.
Dr. Sushi, you want to add?
In most of the cases, our PET scan, most of the time it is doing with the contrast also. So very small lesion we can pick up in PET scan with contrast. But if any doubt is there, then only we do the contrast enhanced MRI.
Usually most of the center, they use CT without contrast in combination with PET CT. So
No,
some
but-
center might be using, but
Yes,
by
yes.
default, most of the center, I think everyone agrees, they are not using contrast. Having said that, issue with RCC brain mets versus lung metastasis is asymptomatic in vast majority of the cases, like at the time of diagnosis. But in case of renal cell carcinoma, that's usually a symptomatic disease. Even if bone disease, that is also usually a symptomatic disease. So unless patient is having specific symptoms or you are having some strong clinical suspicion based on biochemistry, then only addition of brain imaging or bone imaging can add, but otherwise just simple contrast in CT scan abdominal thorax is good enough to make our initial decision. So anyways, the patient was subjected to PET CT and on PET CT, these were the images. Patient was having exophytic 9 into 8 into 7 centimeter right kidney mass with axillary lymphadenopathy and multiple pulmonary metastases. So coming to our pathology colleagues, so when such patient is referred, coming to your department and clinician asks whether you would like to see FNAC or biopsy, core needle biopsy, excision biopsy, as a pathologist, what is your point of view in renal cell carcinoma diagnosis from pathology point of view? Are you happy with FNAC, small tissue biopsy or good tissue true cut biopsy?
The first line of treatment, first line of diagnosis will be the FNAC. First of all, we'll go for the fine needle aspiration. Biopsies are not recommended because of the danger of hemorrhage. So mostly we go for the fine needle aspiration. And with aspiration, we are able to diagnose the type. Firstly, we will diagnose whether it is carcinomatous, the tumor is carcinomatous, and also we can subtype the tumor.
So that's going to prove whether it's a malignant lesion or non-malignant lesion. That can be easily done with FNAC. I think that's what you are trying to convey. So there is no need of true cut in that case. But in RCC, actually the management differs. Yes, ma'am, you want to add?
If percutaneous biopsy can be afforded, then I think better we will go for biopsies because there we can categorize better. In some regions, we cannot categorize between clear cell and non-clear cell. And so renal cancers are usually to be diagnosed towards clear cell or non-clear cell so that we can guide the therapist for the therapy of the patient. So better to go for a biopsy and so that we can label them. Sometimes in FNAC, we cannot categorize the lesions which have mixed features as these can be clear cell or non-clear cell.
So that was my next question because FNAC, yes, ma'am.
For the cell blocks from the end, FNAC aspirates. If we make cell blocks, then we are able to differentiate between the clear cell and non-clear cell.
So
Plus, we can do the IHC on the cell blocks.
So you are comfortable with FNA with cell block. You can clearly give a diagnosis of clear cell versus non-clear cell.
I think we are able to differentiate.
So because from clinical point of view, that's the only distinction we want to make. Even if patient is not a candidate for systemic therapy, we are planning for surgery. For that matter, that's going to be next discussion. So for cytoreductive purposes also, we need to have that clear-cut information whether patient is having clear histology or non-clear cell. So our purpose is not to diagnose the case of malignancy as such. That's obviously important. But next up, what we are going to do next will be defined based on whether it's a clear cell histology or non-clear cell history. Any role of molecular profiling in RCC in 2023? Any of both of you can take this question.
So molecular profiling can help. There are certain mutations which can help, like if we see MET mutations and VHL gene mutations, they can help the patient.
So that can aid our decision making in terms of genetic counseling and further profiling of the patient in terms of genetic counseling. So can you make a diagnosis just on the basis of gross appearance of sarcomatoid histology or chromophobe histology, or do we need IHC immunohistochemistry in such?
Can be diagnosed on the cytological findings of the cells. So we can appreciate the sarcomatoid changes in a cell, and we can grade those tumors as high grade. They are grade 4 tumors. And all the subtypes of the RCC can change into sarcomatoid variants.
So coming to that question only. So is there any relevance or reporting proportion of sarcomatoid differentiation?
Even if the small portion is sarcomatoid, it's a high grade tumor.
Okay, no, so that's going to add to our information whether it's a non-clear cell histology, relatively poorer risk. But the proportion of sarcomatoid can add to our decision making in terms of what type of therapy we are choosing. So that's why I was asking. Are you routinely reporting proportion of sarcomatoid component?
No, the number of renal tumors coming to our department is very less. So, and for to sarcomatoid variants are very rare.
So
I
our
can't
clinician
comment on-
colleagues, so would you like to add to anything? What are your expectations when someone is reporting sarcomatoid histology? Sir, you can take it.
Actually, these are bad subtypes. Whenever we usually it's more important in within the nephrectomy specimens to clearly tell what percentage is sarcomatide, because in FNA you might have not hit the sarcomatide part, but on nephrectomy it's easy to tell what proportion, because if sarcomatide is more, then chemotherapy has to be given, like adriamycin based or something. Otherwise TKIs and immunotherapy.
So
These are
coming
the
back to
standard.
the original question, so in that case, it's better to get a tissue diagnosis. But having said that, fine needle aspiration is good enough for initial decision making. For example, if you are planning cytoreductive surgery, in that case, anyways, we are going to have adequate specimen for further testing, whatever testing we can do, even further genetic profile. So, Lalit sir, are you offering genetic testing in RCC patient? And if yes, what are the group of the patient that you would like to offer genetic profile?
Let's gradually we are moving towards more of personalization of therapy. So ideally, I would wish to offer each and every patient of RCC comprehensive genomic profiling rather than going for sequential testing. But having said that, that is what guidelines and what is that is what we wish. But in practice, I believe less than 10% of the patients are getting comprehensive genomic profiling. So
So that comprehensive genomic profile for therapeutic purpose is different thing. So this is a genetic profile for familial predisposition. Dr. Satyankar, you would like to add to?
You've shown that slide. Just in case we come across a young patient with 2 or more, first degree relatives having, be diagnosed with this RCC, only in that case, not for
So
everybody.
message is a small proportion of the patient are actually having familial predisposition, especially those who are having less than 45 years of age. There is multifocality of the tumor. There is any family history of first degree, second degree relative affected by malignancy. In such cases, you should offer genetic profiling. And how that's going to change anything? We are having certain approvals based on genetic profiling now. So that can change the type of management we are going to offer to the patient. So that is important, not just for the diagnostic sake, not just for the family counseling for the sake, but for further treatment planning for that particular index case also. So that's important, and that we should keep in our mind. So when our next patient is coming and we are having strong suspicion of familial predisposition, we should try to offer if patient is affording genetic counseling testing. Now coming to the continuation of workup. This patient underwent FNEC, which is standard practice in most of the center, and malignancy was proven. Malignancy was revealed to be a clear cell histology, and genetic testing was not done. So coming to radiation oncologist. So, sir, if such patient comes with a clear cell histology, patient is having axillary lymphadenopathy, few pulmonary nodules, and main disease is limited to abdomen only. So, how are you going to proceed further in such case?
Sir, we'll do risk stratification. of
Limited
this-
metastatic clear cell carcinoma.
We'll do risk stratification of these patients upfront, then followed by depending upon the risk of the patient fall in whatever category of the risk, we'll start the treatment of those patients.
So Dr. Sushil, such patients usually come to surgeons first, and they need to go to the initial workup and risk stratification, then only discussion regarding whether we are going to offer cytoreductive surgery or not. So what kind of risk scoring you are using in your clinical practice?
So in low risk, we can do surgery. We do the surgery, basically, low risk patient.
What
Okay.
kind of risk scoring you are using in your practice? So Dr. Satyankar, Dr. Lalit, what is the standard of care at your center?
I am comfortable with this IMDC based. So largely they are the same. We just have to categorize between favorable and intermediate.
Idea is that both MSKCC scoring or IMDC scoring are universally used throughout globe. Issue is the database of IMDC is more refined in terms of newer therapeutic modality. So that is will be able to predict better outcomes in terms if patient is offered TKI and for that matter even immunotherapy. There is no clear-cut information regarding immunotherapy as of now, but the current database suggests that if patient is offered TKI at least, in that case IMDC is going to offer a better predictive information as compared to MSKCC. So coming to the the question that we are discussing for a decade or so, whether we should continue offering patients cytoreductive nephrectomy or not, especially with the evolution of medical oncology and incorporation of immuno-oncological drugs, TKIs, now combination of immuno-oncological drugs, the combination of IO plus IOs. So we are having so many therapeutic options. And now survival, we are looking at 10-year survival. We are not even looking at 5-year survival in kidney. So in that case, what is the justification of offering such an invasive procedure, cytoreductive nephrectomy, if we can go away with just systemic therapy for that matter, just oral treatment? Dr. Sushil, would you like to take this case?
Yeah, for low risk patient, I would like to do cytoreductive nephrectomy.
Any difference of opinion?
As always, a major difference of opinion. I know the swords are going to be out now. So when the patient is not very symptomatic, when the hematuria isn't there, so this cytoreduction, is it going to help the patient either in the improvement in the PFS or the overall survival? So that is the bone of contention which has been for long. So
So in oncology, there are always two endpoints. Whatever we are offering, number one, is it going to improve the survival? Number two, is it going to improve quality of life? Everything else is fantasy. So is doing cytoreductive nephrectomy going to improve the survival? So for all patient, answer is no, not for all patients. But a select group of the patient definitely is going to improve the survival. So the selection of patient is important. That's why we discuss risk scoring. So IMDC risk scoring in TKI era is one of the optimum choice that we can have. If there is good risk, there is zero risk factor. In that case, cytoreductive nephrectomy can be offered. So that is part of guidelines also. But having said that, now there is the issue with intermediate risk. So how do you define intermediate? Even just one risk factor is also intermediate risk. Patient is having just renal mass, one isolated pulmonary nodule, intermediate risk score because platelet count is 1,30,000. Then are you comfortable, Dr. Satyankar, are you comfortable offering IU plus PKI to these patients or are going to offer cytoreductive
regarding
nephrectomy?
cytoreductive surgery, I think they have a role. They can't be put out of place. We routinely do it for patients with bleed and other two categories. They are totally out. One is brain metastasis and the other is poor performance status. So you don't operate on them. The other thing is regarding the trial with the sunitinib, that it doesn't have any OS advantage. But I don't think with cytoreductive surgery has been compared with the IO, that is immunotherapy.
So
It
as
has-
with the Carmina trial, surgeons or urologists can fight with us regarding the trial design, the type of data they analyze and everything. That's a debatable issue. But overall, Carmina trial produced some data which that's why we are discussing this. So in a post hoc analysis of Carmina trial, even that intermediate risk of single risk factor, that group of the patient were also getting benefit with cytoreductive surgery. So there is role of cytoreductive surgery with good risk factors, limited metastatic disease. And having said that, now I want to involve our radiation colleagues. So when we are offering cytoreductive surgery, there is always a choice of offering local radiation, especially for oligometastatic disease. And those patients who are already on treatment and they are having oligoprogression, single isolated brain lesion progression or single isolated liver lesion progression. So how do you take the role of radiation oncology versus surgical oncology in such patients, those who are having limited disease burden and that disease burden is oligometastatic by definition?
So if it is resectable, we should go for resection of metastectomy of the disease. And moreover, as we have said, this nephrectomy is also being done initially. But if it is not resectable, like if you're oligometastatic disease where it is not resectable, we can go for SBRT also, or depending upon the location of the disease, we can treat those patients with hypofractionation.
So
protocols.
SBRT, local radiotherapy, is one of the acceptable options, especially for oligometastatic disease. And coming to cytoreductive surgery, limited metastasis, especially there is no brain metastasis, good performance, good IMDC score. Then in such case, you can offer cytoreductive nephrectomy. So one running question, is there any role of observation even in metastatic RCC in 2023? So the
No.
question is open for everyone.
No, I don't think so.
So that's why
Poor performance status,
ma'am, you
limited
want to add-
lifespan, yes, you can spare them. It's not necessary to treat everybody.
Thank you. In this year's Astro, Shankar Shiva from Australia has presented the SABRE data on cytoreductive, stereotactic body radiotherapy for the primary. And there are already questions being asked about doing an RCT between stereotactic body radiosurgery and nephrectomy in RCC. I just wanted to mention this point.
So there is some evidence that a small select group of the patient, they can even offer observation. And that is also part of guidelines. That is category 2A recommendation. That is just one step before that category 1 recommendation. So there is recommendation of surveillance in a select group of the patient. What are those select group? And there is this evidence. Even there is phase 2 prospective trial. Latest update was published in 2021 only. So what they are saying it's a category 2A recommendation, those who are having very limited asymptomatic good risk or favorable risk. Such patients, especially elderly patients, those who are having comorbidities, even TKI can be problem for such patients. So observation can be one such option for such patients. So anyways, patient was planned for systemic therapy after MDT discussion. Now coming to medical oncology colleague again. How do you decide, since we are spoiled by choices, we are having so many options right now, category 1 to category 2B, even category 3. So how do you choose first line therapy? We will start with Dr. Satyakar, then Dr. Lalit can add. So what goes in your OPD practice in your clinics? That how you
Just it's basically if we have undergone, the patient has undergone a cytoreductive surgery and then first line choice, then my preference would be pembrolizumab and
patient has not undergone cytoreductive surgery. Patient is having
only
extensive metastasis, intermediate to poor.
still it would be pembro plus exitinib.
So there is no patient for TKI alone in your setting.
Yeah, affordability is there. If there is not an if the patient is unaffordable, then obviously TKI is the option. And out of TKIs, I would definitely prefer sunitinib.
So Dr. Lalit, risk scoring is going to change your treatment offer, the treatment plan that you are offering patient, TKI alone, TKI plus IO, yeah, IU plus IO.
Well, majority of my patients, if both intermediate and high risks, they land up on TK and IU combination. But having said that, ideally, I would like to go for the CGP profile, comprehensive profiling upfront and look for any other targetable mutations if they are present. If not, then usually my choice is TKI plus IU.
Which TKI and which IU?
Exitinib plus pembro, and the major reason out of it is because I have more experience with these two molecules, and that is probably the major reason. And plus cabo, I would like to keep it as a next line choice for me.
Right. So especially patient is affordability not an issue. Most of the centers, they are offering TKI plus IO only, and there is category 1 evidence. There are multiple trials that they are showing there is clear-cut survival benefit with this approach. But issue is now there is data of IU plus IU.
Yeah.
So in your practice, because that is also showing strong survival benefit. This is even you can see hazard ratio 0.68 survival hazard. And is there any group of the subgroup of the patient in which you are comfortable offering IO instead of offering TKI plus IO?
I'm not aware of this trial, Nivo EP trial.
I believe one is where you're not very comfortable.
Part
with-
of guideline category 2A recommendation.
Yeah, it is.
So poor risk group of the patient, you can offer IO. They are having good performance score and you are able to predict that the patient is not going to have toxicity. So if ICI is not an option, then how do you choose whether patient to be offered TKI, which TKI is pazopanib versus sunitinib? So that's also age-old question. And now we are having prospective evidence that there is a differential toxicity. Survival outcomes are similar, pazopanib versus sunitinib, but there is a differential toxicity. And in terms of quality of life, this is 2022 paper says that even pazopanib patients, they can fare better as compared to sunitinib. Now coming to our Indian context, those who are not getting treatment at AOI, those who are getting treatment at AIMS and government hospitals, we need to offer just TKI only. So for that, there was this important analysis that was published by Dr. Sudhir Gupta et al. They said that sunitinib is actually cost effective in our setting. And that is at the time when Sutent was available. That was the only drug 2-3 years back. And at that time, after this paper, this was approved and that was included in Ayushman Bharat. So that's why this is one of the treatment option for us. Now, that is also important to consider this option of low dose nivolumab. Since TKI plus IO, that's so much promising result. So low dose immuno-oncological, any take on low dose immunotherapy in RCC?
Yes, I am practicing this now. I have 2 patients, but
So there is evidence, especially there is evidence from Delhi AIMS also. There we are also practicing that. Low dose immunotherapy is going to improve the survival. Although survival, that evidence is not that strong. That is not a prospective phase 3 randomized control trial, but there are retrospective studies. There are smaller cohort studies. There is lab-based study that bioequivalent study that low dose nivolumab is going to add to survival through TKI management. So when patient is on immuno-oncological drugs, what kind of response assessment you are advising to such patients, and what is the frequency of getting response assessment? Radiation oncological, you can also take it. You want to take this?
We can assess the response, I think within 6 weeks or 6 to 16 weeks, we can assess the response of the treatment.
Point is, are you offering early or what is, if you are offering early response assessment to such patients, how you are going to change the further management for such patients? What is the idea behind offering early response assessment? Dr. Satyank, Dr. Lali?
I routinely do it at 3 to 4 months, not before that.
So even if patient is having symptoms early?
Yeah, then we have to, but you said follow up.
So in your practice, have you seen any experience with pseudo progression or hyper progression?
They can happen with ICIs, but since we use, these IO drugs very sparingly, not everybody can afford. But those patients are usually responding, and the response rates are around 40 to 45% with this combination. So usual time is around 3 to 4 months. I have not come across
As
this.
far as available evidence, pulmonary, thoracic malignancies, they are more notorious for that kind of profile. RCC, theoretically, they can also have pseudoprogression hyperproduction, but that incidence is relatively less. So if patient fails on TKI plus IO, how do you plan further lines of management? Dr. Lalit, patient was on exitinib plus pembrolizumab. After 6 months, patient is having clear progressive disease, and that has been proven again by a reconfirmation of PET-CT after 4 weeks. So how are you going to proceed further? Patient is fit, performance score is 1.
So my second line choice here would be cabozantinib. We have now recent data to support cabozantinib even in the frontline setting also. And so yes, cabozantinib would be my next choice.
So
Same here.
TKI plus
IO,
followed by
yeah, only TKI. IO, there's no point in adding IO.
Are you offering everolimus?
Yeah,
So which group of the patient you would like to offer TKI plus everolimus?
TKI plus everolimus. In second line, third line, we can use. No,
Those who are having poor risk.
poor risk, yeah.
Good performance score. And do you expect that such patients to tolerate this everolimus?
So everolimus as a single agent is very difficult to tolerate. So giving it with TKI, but that too in a third line or second line setting.
Coming to next question, any takers for second line different immuno-oncological?
No.
So this is interesting study, this Keynote 146. This is also an interesting publication that is saying that even re-challenge with the TKI plus pembrolizumab. If in first line pembrolizumab was not offered, different TKI was different IU was offered. There are promising results. Final OS is awaited, but there is some evidence. So that's why this can be one of the options, especially if the interval is long and patient was offered different TKI, especially like for example low dose nivolumab. So we can offer pembrolizumab plus TKI. And latest part is that Indian guidelines, these are published just 1 month back on the 9th of August. Dr. Shyam Agarwal is one of the coordinator for these guidelines. And these are also in line with whatever NCCN and ESMO guidelines do. With that, I would like to thank the organizers. Thank you, my panelists. Thank you, chairperson. Thank you, everyone. Thank you for your kindness.
Thank you, Dr. Amit. Thank you.
May I now invite, thanks chairpersons. May I now invite chairpersons for the next session. Dr. Shamim sir. Dr. Arvind sir, you can join us on the stage. So the next lecture is by Dr. Sarupa ma'am. She's come from Fortis Gurgaon. She'll be delivering a lecture on bladder preservation in CA bladder. Then we have two more talks.
Good afternoon, everyone. Let me thank Dr. Deepak, Dr. Satyankar, and everybody in the team for this dedicated work and for giving me a chance to be here. And I'd like to say here that Dr. Deepak has been organizing this since probably 8 to 10 years, and I have never missed even one CRABECON, and every time I have enjoyed it. So my topic is bladder preservation in carcinoma bladder. So I think in my experience, I am getting more cases these days for bladder preservation. That means patients are being aware, and probably the urosurgeons are also getting aware that trimodality treatment or bladder preservation with radiation is an option to be taken.
I'm sorry to disturb. May I request Dr. Nazir Khan sir, HOD Sher Kashmir Institute of Medical Sciences, to chair the session. Sorry, sir, we missed it.
Thank you, sir. So the background, we all know that bladder cancer is the 10th most common cancer in the world. And about 25% of them, that is 1/4 of them, are muscle invasive. And till now, till today, neoadjuvant chemotherapy followed by radical cystectomy with bilateral pelvic lymphadenectomy has been the standard of care. And radical cystectomy has significant impact on quality of life. This is very important for us to understand. The risk of high-grade complications of about 20% and a mortality risk of 3 to 6% do exist. Approximately about 50% of the patients with invasive bladder diseases receive no definitive treatment. This is also very important. There are patients, most of the patients are subjected to radical cystectomy, and that is why many patients silently, they drop treatment, they don't come back for treatment. So we lose 50% of the patients to go without treatment. Ultimate goal of preservation of bladder is the optimal quality of life that is important, and avoiding risks of mortality, morbidity of the radical cystectomy, and maintaining the oncological outcome. Now, muscle invading bladder cancers, bladder removal and reconstruction is one of the treatment, and also bladder conservation. And the goal is the same: cure of the patient, optimizing the survival, prevention of pelvic failure and distant metastasis, functional urinary reservoir, and high quality of life. Now, organ preservation is not new. We have known about organ preservation from our breast cancer patients. We have saved the breasts. We have saved the larynx. We have saved a limb from being amputated. And we have also saved the anal canal without the patients are going without a bag. And these are, we have achieved with very good results. So now it is time to think about the other organs, and bladder being one of them. So rethinking about radical cystectomy as the best choice for most bladder cancer patients. Should we think of, it is time to think for other choices, other options for such patients. Now, results of cystectomy, just we all know about them, but just rethinking, post-operative 90 days readmission rates are 32%. These are all recorded, these are all mentioned in literature. 30-day of readmission rate is 21%. This is the second highest rate of any surgical procedure and only surpassed by multiple mitral valve replacement. So you can see they are why patients do not choose radical cystectomy. The average post-operative length of stay ranges from 7 to 14 days. The morbidity of primary radical cystectomy is also known to us. Overall survival, if we see at the overall survival, it is about 46%, 48%, and 50% 5-year, and 10-year is lesser. So what is the modern alternative to cystectomy? And that is what our topic is. We have unimodal treatment, we have trimodal treatment, and now there is a tetramodal treatment, which I will speak about in one slide later on. So unimodal treatment consists of chemotherapy or radiotherapy, where brachytherapy is a very important part, transurethral resection of bladder, that is the TURBT, and partial cystectomy. So these are the unimodal treatment. And what about the trimodal treatment? We have the maximal TURBT, followed by radiation therapy and chemotherapy. So with all these are the ways we can conserve the bladder. Now, bladder preservation success rates are, you can see with TURBT alone or any unimodal treatment, they are not very high, or 20%, 19%. Complete response rates also, if you see, it is the best with the trimodal treatment, TURBT with chemoradiation, that is about 70 to 80%. So it is suggested and it is recommended that all unimodal treatments are generally inferior to combination treatments or radical cystectomy. Therefore, they should not be routinely offered alone as a curative treatment to all patients. I won't say that there are some indications which I will cover. So TURBT alone, the optimal characteristics of patients undergoing TURBT alone is accessible tumor locations, complete resection with negative TURBT, tumor size 2 to 3 centimeter or less, no multifocal carcinoma in situ, no hydroureteronephrosis, and adequate bladder functions. Only if you have all these, probably that patient can be considered for TURBT alone. And what about partial cystectomy? The advantage the partial cystectomy has over TURBT alone is the accurate staging by lymphadenectomy and full thickness resection with evaluation of the surgical margins. So the ideal candidates are again solitary lesions, and the lesion should be less than 3 to 4 centimeter, where the excision margin with 2 centimeters margin is feasible. An example is the bladder dome. No concomitant CIS, no need for ureteral replantation, and no hydroureteronephrosis, and no hypercontractibility of the bladder. Now, what about radiation therapy as organ preservation? The benefits that radiation has in bladder preservation is that the cystectomy rates, if you see at these figures, the cystectomy rates are decreased by 88 to 125% without radiation. They're increased, I'm sorry. So the cystectomy rates are increased if the radiation is not delivered. Now, these are some of the trials of bladder conservation with different modalities. And in all of them, if you see, the survival with intact bladder is quite good, 45%, 40%, 44%. They are quite good. And this is the survival with intact bladder. So how has this come? So there are 2 pioneering studies based on which today we have the trimodality treatment. One is the MGH and one is the Erlangen. So the difference between the two is that the MGH, they had TURBT followed by an induction radiation and chemotherapy for about 40 grays. After that, they do a restaging in 2 to 3 weeks. And if there is a complete response, they go ahead with the completion radiation with chemotherapy. And if there is an incomplete response, then they go ahead with the cystectomy. So the radiation is done in 2 phases. The Erlangen, on the other hand, is TURBT is done. After that, the entire course of radiation is given, and the restaging is done about 2 to 3 months. And those who have residual disease, they go ahead with cystectomy, and those who have complete response, they go ahead with follow-up. Now, these are some RTOG trials on trimodality treatment. And if you look at the complete response, pathological complete response rates and survival, they are very, very encouraging. This is the survival data. If you compare, there are no head-to-head analysis, but yes, radical cystectomy and selective bladder preservation. These are some of the studies, and they are comparable. The overall survival, pathological complete response rates, they are very, very comparable. Now, radical cystectomy versus organ-preserving trimodality treatment, this is a systematic review. And this also says, compared with radical cystectomy, trimodality treatment is associated with better outcomes for patients with muscle-invasive bladder cancer. And the addition of chemotherapy to this may improve the radical cystectomy outcomes in some subgroups of patients where there is high probability of micrometastasis. Now, these are again some modern papers of our results of trimodality treatment. And these are also, most of them, you can see they have different protocols, and the complete response rate and the salvage rates are very impressive. Now, are there any, like I was just saying, if there are any studies, direct studies, comparison of the radical cystectomy with trimodality treatment? Yes, they are not. There is one study in 2014, which shows that overall survival and disease-free survival rates are comparable with radical cystectomy. But there was another study in 2017 that failed to recruit as initially planned. So this was, this study could not go on. So now what are the bladder sparing protocols we have, which we are practicing? So one is the maximal TURBT followed by, that is the MGH protocol. We give 40 to 45 grays of induction radiation. After 2 to 3 weeks, we go ahead with the evaluation with a cystoscopy. And if there is no tumor, that is a complete response rate, they are sent on follow-up. And if there is a residual tumor, they land up with radical cystectomy. This is the split protocol. We also have a continuous protocol where the maximum TURBT is done and the full dose of radiation of about 60 to 66 grays are delivered. And the evaluation of the response is done in about 2 to 3 months. And those who have no disease, they are on surveillance. And those who have residual disease, they go for radical cystectomy. So this is the continuous protocol. So we have the split protocol, we have the continuous protocol. We have another protocol that is the hypofractionation. So in this, it is the same, the entire dose is given, but it is 55 grays in 20 fractions with chemotherapy. And we'll be talking about this in a later slide also. And the best candidate, how do you choose these patients? So these should be histologically confirmed muscle invasive bladder cancer, more than PT2. And there are some guidelines which says T2, but now we have even T2, T3, T4 patients also going ahead with bladder preservation. Node negative, ECOG good, no previous pelvic radiotherapy, adequate bladder function is very, very important, and adequate renal and bone marrow function because the chemotherapy is also associated. So what about the radiotherapy dose? Like I said, we have the standard EBRT where we give 54 grays and then the boost to the tumor about 64 to 66 grays. And we also have the hypofractionated regimen with 50 to 52.5 in 20 fractions. Now, there is another study where the partial to understand whether partial bladder radiation with tumor boost versus whole bladder radiation, which one is better? So in this study, this is quite an interesting, they have given 55 grays in 20 fraction versus 64 in 32, and 80% of the dose has been given to the whole bladder and the rest to the tumor alone. And here they found that this could not establish the non-inferiority of the outcome of this study. And therefore, both options, they concluded that both options seems to have similar efficacy and toxicity rates and may be used for selected patients. So we can use both of them. Now, a dilemma we always have whenever a bladder patient comes, whether to include the nodes or not. So here is the answer probably. Now, pelvic nodal involvement in muscle invasive about 30% of the patients. But in studies, it has been shown, the conclusion of this study, which was in 2011, that both showed similar rates of bladder preservation and DFS and overall survival. That is, whether you include the nodes or not. So smaller field size, including the bladder with a 2 centimeter margin, can be used for bladder preservation protocol for patients with muscle invasive lymph node negative bladder cancer. So this is what was the outcome or the suggestion from this study. Finish. So split course or continuous regimen, there's no prospective trial which one is better than the other. So you could use either of them. Role of concurrent chemotherapy, yes, cisplatin, paclitaxel, 5-FU, mitomycin, gemcitabine. So these have all been used as a tumor hypoxia reducing agent, and they have been used as sensitizer also. Neoadjuvant chemotherapy for transitional cell, yes, absolute survival benefit is about 6.5% with neoadjuvant chemotherapy. Now there are concerns about bladder conservation. It delays definitive surgical treatment, the toxicity of radiation therapy on bladder functions, and field cancerization effects. So these are the concerns we have as radiation oncologists for bladder conservation. So how do we choose the right patient? So that is actually the key. Primary T2 tumors, but like I said, we are using even higher T stages as well. Unifocal, no CSI, tumors less than 5 centimeter in the maximum diameter, no ureteric obstruction, good capacity of the bladder, visible complete TURBT, and very, very important, which I have mentioned in red, willing for being on close surveillance. The patient has to understand that he or she has to be on close surveillance. And also they should be willing for cystectomy in case there is a relapse for progression. So we have to counsel these patients when we take them up for bladder conservation. So the NCCN guidelines in 2023, they have added bladder conservation with trimodality treatment as a treatment option. Now, I was talking of tetramodal protocol. So this is a new protocol, new concept which has come up. So in this, there is a maximal TURBT, then inductions, concomitant CTRT are given 40 grays, then evaluation at 40 grays, then the evaluation is done with the cystoscopy. If there is residual tumor, they go for radical cystectomy. And if there is no residual tumor, so earlier we had in other protocols, we had boosting up or for follow-up, but in this case, they are going for partial cystectomy. So this is the tetramodal protocol. So this is very new. Quality of life, which is very important. So most of the studies we have seen that they have very good quality of life. So this is a study where 78% have compliant bladder, 85% had no urgency, 25% had occasional moderate bowel control symptoms, and 50% have normal erectile functions. Similar studies in the RTOG studies also, they have most of the quality of life has been very good. So these are also various studies that get to 97015, and these are the rates of severe, acute, and late toxicities during the trimodal treatment. So the closing thoughts: good complete response preserves the native bladder in 70. This is about the combined modality treatment. More than 70% of the patients' quality of life studies show that the retained native bladder functions are good. Long-term survival rates are comparable to radical cystectomy. Long-term toxicity of trimodality treatment is relatively low. Morbidity of salvage cystectomy is comparable to primary cystectomy. Unique opportunity for urological surgeons, radiation oncologists, and medical oncologists to work hand in hand in the truly multidisciplinary effort. So this is actually the takeaway message for a combined modality treatment. Thank you.
Ma'am, I'm Dr. Ilyas Sharma. I'm a urologist. So very interesting slide, the last one which you told, the tetra modality, where you upfront give radiation and then see the tumor response. And you have also told that studies have proved there is no extra morbidity post, I mean, salvage. If there is, radiation already been given to bladder and then you operate, the morbidity is same. But our practical experience is once the bladder is irradiated, we find a lot of adhesions there, and similarly the bowel also there are concerns because we do an osmosis. Sometimes the bowel comes into that field, and there is ischemia in the blood, bowel. So these are our primary concerns. Whenever there is irradiation to the bladder and bowel, we are very hesitant to go in as a surgeon. And I just wanted to, but of course you have pointed out that the large scale studies have proved there is no difference. But this is my concern.
Yes,
Thank you.
I'm so happy that you asked this question, because I too wanted to clarify many things. Like there was a slide I showed whether to include the nodes or not. So many times nowadays, most of the time, if the nodes is not very advanced, we are treating only the bladder. So your concerns for the bowel is much less. And the second is that we are going for a hypofractionated dose, so which is much lesser. So when I was working in Rajiv Gandhi, we had done 5-6 cases of bladder preservation, and 2 of them are on follow-up. They did not need surgery since the past 3 years. And 1 patient needed surgery. And Dr. Rawal had got back to me and he said that I didn't have any problem in removing the bladder. But of course, this is just 1 patient I'm talking about. But it's good that you brought this question up. Yes, yes, yes. Yes, I'm sure.
Excellent talk, ma'am. I just want to clear for myself. And for example, stage 2B and 0 in pelvisan. Can we take it just with SBRT partial addition to bladder, or we will include whole bladder in the target?
So we are treating the whole bladder with hypofractionated. Partial bladder I have not done. I have not seen anybody done. So just 1 study I found, but I'm not doing it. Ma'am, maybe to say if there is any partial bladder, anybody doing. We are not doing any partial bladder.
I was reading in literature, there are some studies, no, they are saying that partially if it is localized, there is no multi-sentence for it, they can be taken as no partial.
Ma'am, are you using tetra model?
Partial bladder.
Yeah.
That's what I said. I don't have any experience.
And what should be the dosage if we use it? What should be the dosage schedules?
We are treating hypofractionated with 45 to 50 grays in 20 fractions.
Thank you.
And they've been well tolerated.
Thank you.
And in fact, I found them better than the 64 to 66 grays we were giving.
Okay.
Tolerability well.
Thank you, ma'am.
Pardon?
I got it.
Not getting. Can't hear.
Okay, ma'am, I'll ask you afterwards. Now I invite Dr. Indu Bansal from Gurugram. She's a leading radiation oncologist in Gurugram, and she will be speaking on SBRT in localized CA prostate. Please, ma'am.
Good morning, everyone. And at the outset, I would like to thank Dr. Deepak, Dr. Satyankar, and whole of the organizing team of CRABECON. And it has been really wonderful here. And I want to thank them for all the hospitality extended. We really enjoyed I really enjoyed my stay here for the last 2 days. So I'm going to talk on a very interesting topic, which is very, very close to my heart. That is SBRT, means stereotactic body radiotherapy, because it hits harder, it hits faster, it's a very smarter modality of delivering radiation, and definitely it's cheaper for the prostate cancer patients. And I think the best part about it is that it's an OPD treatment, 5 minutes treatment. You can go to the work same day, you can travel. The treatment finishes within a week. So patient can, outstation patients, they come to us, they fly on a Monday, and next Saturday they are back to their countries also. So I'm really very happy doing this SBRT in my patients. So actually, what is the difference between SBRT is that in a conventional fractionation, we give 5 days in a week, 2 gray per fraction, and it is extended for a period of say 6 to 7 weeks. Normally 38 fractions are given. But in a moderate fractionation, you increase the dose per fraction and you reduce the number of fractions, and it gives the same efficacy. So you reduce from 38 fractions to say 20, 25 fractions or 28 fractions. And ultra hypofractionation is that you give more than 5 gray per fraction. And the treatment is given usually on alternate days, and they are usually 5 fractions. So a large multi-institutional consortium report of 1,100 patients treated with SBRT with a 5-year follow-up showed biochemical recurrence-free survival rate of 95%, which is excellent for low-risk disease, and 84% for intermediate risk disease. And in fact, the role of SBRT is now emerging for high-risk patients as well, means people with more than 20 PSA and high-risk features. So this is the risk stratification for prostate cancer, and we all know that the established role for SBRT till now is for low risk, favorable intermediate risk, but of course it is emerging for unfavorable intermediate risk as well as for high-risk patients, where we have started treating the pelvic lymph nodes as well. So this is my talk. My talk will flow on indications, rationale, image acquisition, some contouring tips, whether to use SBRT for low risk, intermediate risk, and as well as for high risk. There is some role of SBRT for recurrence as well. Should we do urethral sparing while doing SBRT? Dose constraints, toxicity, important trials, dose escalation, and where you give even a single fraction radiation, single sitting 5-minute treatment, and patient is cured of prostate cancer. And of course, proton treatment, but I will not speak much because Dr. Sapna is there with an authority on protons. So I would skip that part. So why do we need SBRT? Because radiobiological studies have shown that prostate cancer has a very low alpha beta ratio, which is to the tune of 1.5. And it ranges from 0.47 to 4.14. The interesting part is that after SBRT, the normal dose that we use is 35 to 36.25 gray. But with 32.5 gray, the percentage of positive biopsy rate at 2 years drops is 38%. But if you increase the dose to 40 gray, the percentage of positive biopsy rates drops down to just 10%, which is quite impressive. So which all patients should you include for SBRT? So this is actually an alternative for radical prostatectomy. I'm sorry, I'm not taking the surgeons out of this, but this is an additional modality of treatment. So any patient who is less than 80 years of age with a good performance status of ECOG less than 2, PSA less than 20, early stage T1, T2, histologically proven, where you don't want to treat the lymph nodes. But there is a data emerging for treating lymph nodes as well. Then no diabetes mellitus, no distant metastasis. And if TURP has been done, then the patient should be taken up at least 6 weeks after TURP. No unilateral or bilateral hip prosthesis because it interferes with image acquisition, which is very, very important while doing SBRT. The patients who have diabetes or who are on anticoagulant drugs, or patients for whom we want to put in a spacer to separate the rectum from the prostate, in these patients, they should not be, they should be excluded. For intermediate and high-risk patients, hormone treatment should be combined. So before we treat any patient, I think all the surgeons, when they do radical prostatectomy, they calculate the IPSS score and the SHIM score. But as radiation oncologists, sometimes we don't do that. So I would strongly recommend to do IPSS scoring and SHIM scoring before SBRT, 3 months post-treatment, 6 months post-treatment, and later on also. So for IPSS severe, it is 20 to 35, but for no significant erectile dysfunction, it is 22 to 25. So please, as residents, we must learn about these scores. So how do we do SBRT? Basically, when a patient is decided, then we give them all the instructions. they should come with at least 4 hours fasting. And the patients should be encouraged, ideally they should be on a low fiber diet for at least 3 to 4 days prior to your SBRT protocol. The patients are asked to evacuate the bladder, drink 500 ml of water, wait for half an hour, and then ideally there should be no gas in the rectum. So we give them some medicines to take the gas before, say charcoal tablets a night before the radiation planning. At the time of simulation, please ensure that the rectum distension should be less than 3.5 centimeter, because if there is more gas, it would put the rectum in the radiation field and lead to more toxicities. The bladder volume should be replicated. It should be within 50 ml of your planning CT scan and on the days that you treat. Ideally, if there are fiducial markers should be placed, because we are giving very high dose of radiation. So we want that our radiation is exactly fitting, or it is enveloping the tumor area. So if by chance you are not able to put fiducial markers, then intraprostatic calcifications can be used as a marker. In Western countries, people use hydrogel spacers, which means it's a spacer which is put between the rectum and the prostate, posterior end of prostate, to displace the rectum away from the prostate. Sorry. MRI scans should be done. Anemia should be done before simulation and before every fraction. There should be fusion of CT and MRI images. And the seminal vesicles should be included in the treatment field if the risk is intermediate risk, or 1.4 centimeter should be included. But for high risk cases, at least 2.2 centimeter of seminal vesicle or whole of the seminal vesicle should be in the treatment field. So this is what you can see here, that there is these are the two fiducial markers which are used for matching the image on the day that you took a scan and then on the day of treatment. Ideally, we place 4 fiducial markers under trust guidance, and there should be at least 2 centimeter. Can I have the marker? Yeah. So ideally, there should be 2 centimeter gap between the two fiducials. There should be 15-degree angulation. The marker should be placed at least 7 days prior to your treatment and prior to taking any CT scan or MRI. And patient should be on a low fiber diet before you put the markers. The goal of fiducial tracking is to keep the translational shift less than 2 millimeter and rotational shift to less than 5 degree, especially if you are treating the seminal vesicles as well. Because if there is any change of shift of fiducial marker by even 1 mm, we consider it as migration. So how to reduce the toxicity? So this is something which is very interesting, which is a Calypso, which is a medical 4D localization system. It utilizes the radio frequency waves for wireless tracking during the radiation therapy. So 3 small 8 millimeter length to 2 millimeter beacon transponders are implanted in or near the target, and each consists of an AC electromagnetic resonance circuit, which is encapsulated in glass, and you can visualize it during treatment. So if you are doing single fraction radiation or very high dose treatments, say in 2 treatments, then ideally these should be used for better localization so that you can reduce your radiation margins. So this is something that I was talking about, hydrogen spacers. So this is a spacer which is placed between the posterior part of the prostate and the anterior wall of rectum. So you can see that it increases the distance between the prostate and the rectum. So the doses to the rectum, they're definitely very much reduced. So if you use these spacers, then the rectal volume receiving at least 70 gray irradiation was only 3.5%, but it is 10.4% if you are not using any spacer. And similarly, the late grade 2 or higher rectal toxic effects in the spacer group were only 1.5%, which is close to 6% if you are not using a spacer. So points to remember for simulation: CT scan and MRI has to be used. Sorry, CT scan and MRI have to be used. Please use P1 contrast, T2 weighted, FSC, TSC, DCE, all these images, and give IV contrast 10 minutes prior to scan. Allow the physical movements of the pelvis before simulation to allow good simulation distribution of the contrast. CT slices that we take for SBRT should be very thin slices, 2 millimeters, starting from the superior border of femoral heads to the inferior border of ischial tuberosity. Now, because it's not a very radiation dominant gathering, so I will not go much into the details of contouring, but just few tips how to identify where is the prostate. So prostate sits just above the urogenital diaphragm, which sits just above the penile bulb. So where the levator ani muscles converge, this is the area where there is a urogenital diaphragm. And the prostate apex is located 1 centimeter above the upper limit of the penile bulb. So we have to exclude the penile bulb to preserve the potency of the patient. If there is extra capsular extension, then we give extra 3 millimeter margin in all directions except in the rectal area. For seminal vesicles, for intermediate risk, 1.4 centimeter of seminal vesicle is included, while for high risk, at least 2.2 centimeter of seminal vesicles are included. Please take care not to include the deferent ducts, cranial and medial to seminal vesicles, because it would otherwise add to toxicity. So anybody who is doing SPRT or doing prostate radiation cannot treat a patient without reading these guidelines, which are for pelvic nodal delineation. So these are the different tiles of SBRT for low and intermediate risk. So these are the usual doses which are used, say 6.75 gray into 5 fractions, which is, so we are, instead of 78 gray in 38 fractions, we are giving a 6.25 gray in 5 fractions per fraction. So which means that biologically equivalent dose, if you are treating if you are giving 36.25 gray or 37.5 gray, the BED is 168 to 178. But if you go up to 40 gray, in 40 gray, then it is 40 gray goes up to the BED's biologically effective dose is 200. And if you give 24 gray in a single fraction, then please note the BED, which is 312. So we have to be very, very careful in the doses that we are giving. So very interesting article, PACE A trial, where they compared the results of SPRT to radical prostatectomy. So this is a recently conducted study. Patients were recruited up to February 22, 123 men from 10 centers in UK. So they compared 36.25 gray in 5 fractions SPRT to radical prostatectomy. No ADT was given. And what they realized was that at 2 years, fewer SPRT patients reported use of urinary pads, only 4.5% versus 46% of patients still using urinary pads. Similarly, there was less sexual domain score for SPRT patients. It was 29.3 versus 58 for patients who underwent prostatectomy. There was no difference in urinary subdomain scores, but just remember that SPRT patients, they had slightly high bowel domains, inferior domains, but the bowel toxicity normalized at 2 years. So this is hypo-RT prostate cancer protocol, where they compared 78 gray in 39 fractions to 42.7 gray in 7 fractions, 1,200 patients. And so the 5-year freedom from failure was 84% in both the treatment arms. The toxicity was slightly more, urinary toxicity was slightly more in the hypofractionation arm, 28% versus 23%. Urinary toxicity was slightly more, 5% versus 1%. So almost equivalent results of hypo-RT-PC. So how beautiful it is that you reduce the number of fractions from 38 fractions to just 7 days, 5 minutes treatment, alternate days, OPD procedure. Patient can go to the office on the same day and work. Another trial, PACE B trial, where they compared 78 gray in 39 fractions or 62 gray in 20 fractions to 36.25 gray in 5 fractions. And here again, the grade 2 genitourinary toxicity or GI toxicity was equivalent. So it is not showing any inferior results and no added toxicity. Should we use SPRT for unfavorable intermediate risk? That's also another interesting paper where they treated 558 men were compared to more than 40,000 men with conventional or moderate hypofractionation. And here also you can see that the curves are absolutely hugging each other. Even for high intermediate risk, 6-year overall survival was equivalent 80% to in both the arms, SBRT versus conventional external beam radiation. So long-term outcomes for low risk and intermediate risk. So here in this white, you can see the lowermost part where you can see that 7-year biochemical recurrence was 4.5% for low risk, 8.6 for favorable intermediate risk, and 14.9% for unfavorable intermediate risk. The GI toxicities, if you see in the lowermost bar in white, it shows the lowest toxicity GU as well as GI toxicity as compared to conventional protocols. So these are the major prostate trials where SHARP trial, which compared 33.5 grain 5 fractions, but here the ADT was used in 72% of the patients. 4-year biochemical recurrence-free survival was 81%. Hypo-RT-PC and PACE-B I've discussed before. Some people have tried to give 40 grain 5 fractions to prostate and 33 in 5 fractions to the PTV, and also treated nodes 25 in 5 fractions. So, but in this trial, the grade 2 GU toxicity was very much high, 52%. But mind you, 30% patients had baseline urinary toxicity. So I will go into this slide also I prepared, and I tried to concise all the trials for high-risk patients. So this is a very, very interesting study because we have a data from the PRIME trial, which is Tata Memorial study from Murthy et al. So they did very interesting thing. What they did was that they gave 35 to 37.5 grain 5 fractions to the prostate and seminal vesicles. But this is the only study where they boosted the nodes also. They gave the same dose to the nodes, to the gross nodes, and they gave 25 grain 5 fractions to the pelvis. They reduced the PTV margins, and even then you can see that 18 months biochemical control rate was 94%. The grade 2 GU-GI toxicity was very, very much less. I'm not going into details in a short of time. People are now giving extra dose to the dominant intraprostatic nodule. Just 2 more slides. So what they are doing is that they give 35 grain 5 fractions to the prostate and 50 gray to the dominant nodule. So this study is going on. Another study, SPARK trial and SABRE trials, they're also doing the same. So I will not go into details of these trials. So, but what you can see here that even for high-risk patients, 2-year control rates range from 82 to 100%, and even at 7 years, 71% control rates, which is quite magnificent. And can you treat SBRT for large, ultra large, more than 100 cc? So here the means they gave 35 in more than 100 cc. Median prostate volume was 139 cc. And even then, the biochemical recurrence-free survival was 100% at 5 years. So SBRT can be used for ultra large glands also. We should be careful about the urethral doses in such patients. I will not go into details of these trials. And this is a very recent work where they gave single fraction radiation, 24 gray, single shot treatment to the prostate. But mind you, this you can do only if you have a robust MRI guidance. You're treating the patient on an MR linear accelerator. You put an endorectal balloon to spare the prostate and the rectum. You put a urinary catheter with 3 beacon transporters to see the bladder movement. And they gave PTV margin of 2 millimeter only, no margin at the rectum. They gave DEXA, oral ciprofloxacin, and oral tamsulosin before treating these patients. And you can see that high 48-month actuarial recurrence-free survival rate of 85.7%. 85.7%. So, and interesting slide is that now we are combining SBRT with brachytherapy. So 25 gray 5 fractions pelvis plus ADT plus 40 gray 5 fraction SBRT boost, which is being compared to brachytherapy. So whenever you're treating any patient with SBRT, don't use, be very careful about the dose constraints that you are using, because they would vary for hydrogel spacer for the protocol that you are using. So my take homes are SBRT can be considered as an alternative to conventionally fractionated regimes at clinics with appropriate technology, physics and clinical expertise. It is associated with reduced cost and less regret about undergoing treatment compared with other regimens. It leads to biochemical recurrence-free survival rate of 95% for low risk and 84% for intermediate risk. And even for high-risk cases, the data is emerging, but we have to be careful about the use of androgen deprivation therapy, and we have to treat the nodes. So that's all I have to say. And I would encourage everyone to refer the patients to such centers which are doing these protocols. Thank you so much. Yeah.
I think we can take questions afterwards because we're running short of time. There are faculties who have to take flights. So I invite now Dr. Sapna Nangia ma'am, and she is the only proton expert over here. Proton is the new buzz in oncology, and ma'am is expert in it. So we have called her from Chennai, Apollo Chennai, and ma'am has been kind enough. I am thankful to ma'am.
Thank you very much. I'm delighted to be here. And thank you so much, Dr. Brol, for this opportunity. My talk today is entitled, I was given the brief that I should discuss proton therapy, hope or hype. And I would like to begin by giving the definition of hope and hype. Hope is a feeling of expectation and desire for a particular thing to happen. And hype is extravagant or intensive publicity or promotion. So what is it that we as oncologists hope for? I think we as oncologists hope for better outcomes for our patients, and we hope for less toxicity for our patients. So is this what we are getting from proton therapy is what I'm here to discuss. There is, of course, a lot of interest in proton therapy all over the world. That is because in the recent years, the number of proton therapy units, as you can see, has more than trebled in the last 10 years, as you can see here. Okay, that's fine. Thank you. So for the non-radiation oncologists in the audience here, I would like to explain this using this cartoon. This is a tumor, the white block that you're seeing. Normal X-rays attenuate, deposit their energy as they go into the body, and continue to deposit their energy before and after the tumor. However, with protons, what happens is that the energy is deposited at a particular point that you have defined as the depth, the maximum depth of the target. And subsequently, as you can see, a bit of the tumor is still missing. So you use a smaller energy and you use another smaller energy till you have covered the whole tumor. And this is called the spread out Bragg peak, Bragg with a double G, named for the scientist who has identified this phenomenon. Now, what does this help us to do when we are able to cut off the radiation at a particular point? What does it help us to do? It helps us to spare normal structures. So if there's a normal structure which is very close to the target, we are able to give a lesser dose to it. Because we are able to give a lesser dose to it, we can often escalate the dose. Or it can be that we don't have to compromise the dose because we are able to deliver the dose that we want to the tumor without damaging a nearby structure. And we are able to exploit radiobiology. What do I mean by that? Normal radiation causes the DNA to break the single strand as well as the double strands to break. Single strands are possible, easier to repair. With proton therapy, the damage is mostly in the form of double-stranded DNA breaks, which are more difficult to repair, and which is the basis of its use in radio-resistant malignancies. Now, the older generation of proton therapy machines were very cumbersome. They required the creation of individualized compensators. They only allowed the dose to be curtailed distal to the tumor, but did not allow, the blue is indicating the dose of that structure that you're seeing, the target. So it controlled the dose behind, but not in front. So these were the earlier techniques, but currently the technique that is used is called the pencil beam scanning technique. So the proton is emitted as 1 3-millimeter beam, which is then layering the tumor, as you can see, and that allows us to give the protons in a very conformal manner. The other issue that is the new development that has happened is that while the earlier machines required cyclotrons and gantries, this is the one that we have at the Apollo Proton Cancer Center, similar to that. So the proton is produced at this point in the cyclotron and then into these treatment rooms. the newer proton therapy machines, which is what the younger people in the audience will be able to practice, maybe about 5 to 10 years from now, are single compacted units which can be put in existing linear accelerator bunkers. So whenever we are talking about the role of proton therapy, very often it is colored by our ability to access the technology. Why I want to stress is that like in IMRT, we saw a transition happening when people could not access the technology. We are seeing the same phenomenon wherein proton therapy may not be accessible right now, but will become in the years to come. So I'll begin by sharing some of the indications of proton therapy. The time that I have does not allow me to discuss all the treatment indications, and therefore I will be focusing on certain areas that I am working on. So the first I would like to talk about is proton in re-irradiation. Now, this is a 32-year-old man who, when he was 23, 9 years ago, had received treatment for a sinonasal endocrine carcinoma, and he had already received a significant dose to both his optic nerves. When the tumor recurred 9 years later, there was naturally a concern that when we were going to re-irradiate him, he was going to get optic neuritis and lose his vision. The calculations were done, and the doses permissible were 27 gray to the brainstem, oral optic chiasm 15, optic nerve 16, and optic nerve left 24. And this is a comparison of his tomotherapy plan with his proton therapy plan. It is quite clear that if we had attempted to treat him with tomotherapy, we would have exceeded the tolerance limits in both his optic nerves, and proton therapy allowed us to give the correct dose to the prescribed dose to the target volume without exceeding the tolerance of the optic nerves. What I'm delighted to also share with you is that about 4 years down the line, the gentleman remains disease-free with intact vision on both sides. This is another young lady who had been treated for an esthesioneuroblastoma. A similar story. The tumor had been, she had come for retreatment. She had already received radiation earlier. She had a tumor which had to be shaved off from the left optic nerve, and we had to necessarily preserve the right optic nerve and the optic chiasm. Now, for equivalent coverage, the blue represents the dose, the maximum dose that we want to give to the optic nerve. Now, the colors that you see for the non-radiation oncologists, the dose that we want to give is represented in red. 57 gray is what we want to give the green volume and the peach volume. And with proton therapy, we are being able to cover the green volume as well as the peach volume with the 57 gray isodose. If we want to keep the dose to the optic nerves the same, you can see that the tumor is being underdosed. This patient went on to remain well for about 2 years and then developed multiple dural metastases and unfortunately passed away. Now, optic nerves, brainstem are, of course, it's like a no area. We know that these are very critical structures. But in re-irradiation, there can be various structures that can become a dose constraint. Like this doctor who had received, 71-year-old physician who had received treatment for carcinoma glottis. Now, when he had received treatment for carcinoma glottis, he had, of course, undergone radiation to the larynx. And he had received a dose of 66 gray in 30 fractions. He then developed a nodal recurrence 4 years later. And this nodal recurrence had to be shaved off from the carotid artery. The surgeon reached out to us to say that he had not been able to clear from the carotids with clear margins. Here, our dose-limiting structure was the larynx, because if this patient receives laryngeal re-irradiation, he is going to develop laryngeal edema and is not going to be, he's going to require a tracheostomy and is not going to be able to practice. So this is his proton therapy plan. As you can see, the larynx is very nicely spared. Both sides of the neck have been treated. And on follow-up, even 1 year post-treatment, we see that he has no laryngeal edema. He continues to see 50 patients a day, is what he told me when he visited us sometime a couple of weeks ago. So this is what the application of proton therapy was in this situation. Now, is it always a success story? No. We must always remember that re-irradiated patients have bad biology. Recurrent patients have bad biology. And if a patient has a very short disease-free interval, then even proton therapy and the double-strand DNA breaks, et cetera, is not going to be able to do anything. For example, in this lady who had a tumor, PET avidity 3 months after treatment, which means that she had a radio-resistant tumor. We did treat her about 4 years later. Till then, she had been carrying on with various immunotherapies, et cetera. We treated her about 4 years later, but within 6 months, the disease was back and she unfortunately passed away. So biology does remain relevant, but yes, we do get some technological advances from proton therapy. So this is the usual way in which we classify patients, not for proton in general, for irradiation. If somebody has done 2 years and has undergone surgery, they have the best outcome. If done 2 years, not undergone surgery, medium outcome. And less than 2 years with a tracheostomy tube or an NG tube have very poor outcomes. And therefore, the choice has to be made very judiciously as to who we are going to offer this treatment to. Recently, some data has been published which has looked at the 2-year overall survival. This has come from a team from Memorial Sloan Kettering who have treated 242 recurrent cancers. And this is approximately 10% more than the figures that have been quoted in the previous last study. So there is some advantage of using proton therapy in re-irradiation settings. This is our own data. We have now treated 38 patients who have undergone 2 courses of radiation. I have excluded the 4 or 5 patients who were treated with the 3rd course because that was done with palliative intent. So the 38 patients who have received radiation, what you see is a very drastic difference between patients who have been treated with squamous histology, where we have a 1-year survival of about 57.6%, versus non-squamous histologies like adenoid cystic carcinoma, where we have seen a 1-year survival in the range of about 84%. We do believe that our 1-year survival is going to become better in due course of time. There is a learning curve in proton therapy, both in selection as well as in technique. We now use hyperfractionated radiation. So these patients are treated as with 1.2 gray twice a day. However, before we, we should not lose sight of the fact that proton therapy is not only for irradiation. Its maximum benefit is derived for patients who are receiving radiation for the first time. And one must not forget that. The first indication is, of course, skull-based tumors. Now, that's a very complicated chondrosarcoma. You can see, I mean, this was a really dramatic CT MRI when we saw this patient with half her, this part of her occipital region all sunken inside. But the neurosurgeon had been daring and had removed a significant part of the tumor with very little residue. But what you see from proton therapy in this patient, perhaps I will show you in the next slide, is that from the high dose, which is 66 gray in red, low dose, which is 56 gray in green, we move to 10% isodose, 5 gray, in just that much distance, which means that the rest of the brain in this very young lady who has a chondrosarcoma, which has a 95% control rate with proton therapy, is actually going to have a reasonable quality of life because we have not irradiated her brain and therefore have preserved her cognition and reduced the chances of having a cerebrovascular accident. So we have now treated 33 patients with clavicle chordomas, and clavicle chordomas, as in all the skull-based chordomas, there are multiple other sites where we have treated. For clavicle chordoma, which is actually considered a very difficult location because of the proximity of the brainstem and the optic apparatus and the temporal lobes, our results have actually been very good, matching with what is there in the literature, wherein patients may have control rates of 80% or more and chondrosarcomas 90% or more, and we've had only 2 progressions and 1 death. Another location which has been found to be very, very useful is proton therapy for skull-based adenoid cystic carcinoma, and we have published our initial experience of 6 patients. We have subsequently added a good number. And as I mentioned, these patients, in spite of having a radio-resistant disease, do remarkably well with proton therapy. The latest studies from Switzerland, the PSI in Switzerland, tell us that the control rates may be upwards of 90% for patients who have skull-base adenoid cystic carcinoma. I'm going to take a little bit of a detour. We were talking about head and neck cancers. Why were we talking about head and neck cancers? Because head and neck cancers are our most common cancer. So what is the experience of proton therapy in countries where head and neck cancer is not the most common cancer? So there, actually, proton therapy in the East Asian countries is most often used for hepatobiliary cancers. Hepatocellular carcinoma is the most common malignancy in Japan, in Korea, in China. And that is where we find, in China, it's actually nasopharynx. So Korea and Japan, we find that hepatobiliary cancers, because they have better outcomes, better overall survival, better sparing of a cirrhotic liver, which is usually the case in a hepatocellular carcinoma. So coming back to our cancer, what is our most common cancer? This is an unresectable head and neck cancer whom we have treated. As you can see, he has presented with proptosis. His eyeball on the right side has popped out. And this is this extremely dramatic lesion extending from his cheek to the infratemporal fossa. We actually naturally told these patients that this was going to be palliative intent, counseled them, did they really want to undergo this treatment? However, they chose to undergo this treatment. This is a comparison of his proton therapy plan with a tomotherapy plan and all the extra radiation that he did not receive because he chose proton therapy, which meant that the parotids received 99% less radiation. Pharyngeal constrictors in middle and inferior, mucosa, spared mucosa, larynx, supraglottic larynx, cricopharyngeus, dramatic reduction in the dose being received by normal structures. I believe the radiation oncologists in this gathering do not need to be informed what the implications of this are. You know, this is our endeavor. We get excited if we are able to reduce the dose of the parotid from 28 to 26. But here you're talking about a global reduction across various organs which impact functions such as swallowing, speaking, dysphagia, aspiration, etc. And what was even more dramatic was the fact that we had a complete response. This man recovered his vision. He had a poor cardiac disease to begin with and an ICD in situ, and unfortunately died 8 months later from his cardiac ailment, but remained disease-free at the time of his death. From then on, we have gone on to treat a number of patients who have inoperable tumors. So this is a 70-year-old lady with an inoperable tongue cancer. That is the proton plan, the tomotherapy plan, the proton plan. The dose distribution in maroon and green that you're seeing are for 32 and 39 gray. These are the 2 doses that have been found to impact the possibility of having mucositis. So definitely in this elderly patient, the ability to cure the cancer, as well as the ability to do it with less toxicity, was very, very relevant. There are other studies. This is an 80-year-old lady. The proton therapy plan on top is giving 10 gray to her buccal mucosa, and the one tomotherapy plan lower down is giving 48 gray to her buccal mucosa. We then went on to publish our experience of sparing the oral mucosa. The oral mucosa is delineated very diligently, the cheek, the gingivum, the lips, the tongue, the palate, etc. And what we see is a significant reduction in the dose being received by the mucosa, which then translates, as we know from this study from Mayo Clinic, in a smaller requirement of opioids, smaller risk of PEG placement, less hospitalization, less end of treatment narcotic use, and better swallow when we look at cohorts of patients treated with proton therapy as well as with photon therapy. The randomized trial is complete and we look forward to its results. But I do believe that For those of us who are of a certain vintage, we did not wait to offer IMRT till Chris Nutting's results became available in 2010. We have been using IMRT for oral tumors for head and neck cancers since 2002. These are called the ASTRO model policies. The American Society of Radiation Oncologists has published these model policies, which are supposed to guide insurance companies about what are the treatments that can be covered. What are the sites that do not require any further evidence generation, that they should be covered with insurance. And these are skull-based tumors, chordoma, chondrosarcomas, cancers of the nasopharynx, nasal cavity, paranasal sinus, advanced stage and unresectable head and neck cancers, where the evidence is thought to be enough to cover these patients with insurance. There are many others. This model policy has been published 2 weeks ago, but for paucity of time, I'm restricting myself only to head and neck cancers. These are group 2 indications. All other head and neck cancers not included in group 1, head and neck cancers with indications of systemic therapy, occult primary of the head and neck cancers requiring ipsilateral radiation such as oral cavity and salivary gland, as long as these patients are being included in a protocol. So we have a protocol called the HENQUAL protocol, in which we are accruing all our patients who are undergoing head and neck and proton radiation. I'll switch gears here to talk about proton therapy for breast cancer. It is usually, till very recently, treated with a disbelief, because proton therapy was thought to be only for brain tumors, for children. But this is actually the fastest growing indication of proton therapy, the fastest growing application of proton therapy in the United States. This is again the ASTRO policy. If you are enrolling these patients in a protocol, a registry protocol, then these patients' insurance should be covered. Who are these patients? Locally advanced breast cancer requiring comprehensive nodal irradiation and various other types of breast cancers. This is our publication recently in the Radiation Oncology Journal, where we have published the application of proton therapy for patients with breast cancer. And you will note in the title that it mentions Indian breast cancer patients. So what is the relevance of proton therapy in Indian breast cancer patients? Are they different from other breast cancer patients? This is called the Q-risk score. This is used by the National Health Service of UK to identify the cardiac risk of patients, not cancer patients, of patients. The risk of having a cardiovascular disease in 10 years. So this is a 60-year-old white lady who has no comorbidities and has a normal BMI. She has a 4.5% risk of having a heart attack in the next 10 years. But if the same woman was Indian, her risk would be 6%. But if this woman was obese, diabetic, hypertensive, and white, her risk would suddenly increase to 13.9%, and an Indian woman's risk would increase to 18%. What is this telling us? Number one, it is telling us that comorbidities treble the risk of having, the baseline risk of having a heart problem. The baseline risk is then what determines what is the risk of having a cardiac disease because of radiation. So this trebling of risk is there because of comorbidities, but most importantly, as you can see, there is a significantly higher risk of an Indian patient having a heart problem, which is approximately about 33% higher risk of having a heart disease. So the relevance of reducing the cardiac toxicity, specifically the discussion is for Indian patients. So proton therapy reduces the dose being received by the left anterior descending artery, both the mean as well as
Sorry to interrupt you, ma'am. You'll have to just
I'll have to
sum it up.
round up. Sure.
Yeah.
So right, left anterior descending, right side also relevant. I'll just come to this Deep inspiratory breath hold is considered the standard of care for our patients, right? Deep inspiratory breath hold is the standard of care for our patients. But proton therapy allows us to reduce the doses significantly more over and above deep inspiratory breath hold. This is what our examination of our cohort of deep inspiratory breath hold with photon versus proton therapy tells us that there is a further reduction, and this becomes very, very relevant in patients who have left-sided disease and comorbidities. I'll skip esophagus, except to say that there is a randomized trial that tells us that the total toxicity burden is dramatically less. 19.1% post-operative complication score versus 2.5%. In India, we have 1 proton therapy unit for every 700 million people. In Europe, which practices socialized medicine, there is 1 proton therapy unit for every 21 million people. So we need to wake up to the fact that there are going to be proton therapy units coming into our country in the future, and we need to be aware of the benefit of proton therapy. My last slide. So definitely, I would like to reinforce that proton therapy is all hope and no hype. I'd like to acknowledge the team at Apollo Proton Cancer Center. Thank you very much.
So much. I think questions can be taken directly to ma'am because of paucity of time. So next speaker, I'll invite Dr. Sandeep on, and I'll request him just to be little short because of paucity of time. Thank you. Dr. Sandeep Mohan is a robotic surgeon at BLK Max. And also request Dr. Ilyas Sharma sir, please come on the dais. You can stay back.
I'll try to be as brief as possible. Good afternoon, everybody. My respected seniors, most of my teachers are here, my colleagues and friends. So without taking much time, I'll come straight away to the topic. Robotic prostatectomy, is it the new standard of care? Briefly about the epidemiology, it's the most commonly diagnosed cancer affecting men after 50 years of age. The incidence is high in European countries and low in our part of the world, basically because of lack of screening and other things. And at autopsy, about 80% of the people over the age of 80 will be having incidentally related prostate cancer. So most of the people die with a prostate cancer rather than because of it. This is the incidence slide, the natural history. It's a slow growing disease. The 5-year survival is as high as 89%, and in 10-year survival with treatment is 63%, while as again in our part of the world is as low as 40% due to lack of awareness and treatment. Screening, as we know, there is digital rectal examination, PSA, and trust guided biopsies. The risk of screening is that we may detect clinically insignificant disease and they may lead to a wild goose chase. And there are false negatives and false positives. A positive DRE is very important. A digital rectal examination is very important because the positive DRE may pick up around 50% of the cases, but that doesn't mean that if the DRE is normal, there is no prostate cancer. PSA, as we know, is a surrogate marker for screening. Sorry, I'm running through the slides. It has the false positive. Suppose if we immediately do after a prostatic massage or a vigorous DRE, a urological instrumentation, ejaculation, a biopsy, prostatitis, infarction, and BPH. PSA velocity is a much sensitive marker and a velocity of more than 0.75 nanogram per ml per year. is clinically very significant to distinguish between people having cancer and no cancer. And a free PSA total ratio of less than 25% is suspicious, while as more than 33% is indicated of a benign disease. Trust biopsies. Now, trust biopsies, we pick up hypoechoic lesions, and of all the CA prostate patients, one third will be either hypoechoic, hyperechoic, and isoechoic. Now, these isoechoic lesions are invisible by trust. 12 core biopsies, as most of us will be aware here. And 20% of the men with CA prostate will require more than 2 sets of biopsies. Local disease staging, we have a CT, PSMA, PET scan, and an MRI. MRI is better in terms of defining the local invasion and disease, whether the sphincter is involved or not, and bladder and rectal involvement. For a distant metastatic disease, we may do a bone scan, or we may straight away do a PSMA PET CT. So pictorial representation of the skeletal mets. Now, staging of the disease. If it's a non-palpable, well-differentiated tumor, waitful watching is enough. No need to do anything. Non-palpable, poorly differentiated tumor, we have to definitely offer a local therapy in terms of either brachy or a prostatectomy, radiotherapy, or a high-intensity focused ultrasound. Stage 2, radical prostatectomy or radiotherapy or HIFU. HIFU is usually not advocated because the failure rates are as high as 40 to 45%. Stage 3 is IMRT, conformal RT, or a teleradiotherapy. And stage 4, metastatic disease. Now, coming to the robotic prostatectomy, this is Da Vinci XI robotic system. It has evolved over years from being S to SI to XI to now single arm. This is the console. This is the docking, how it looks like. Standard 4 small ports. I'll be briefly taking you to the posterior approach. This is the port placement. This is how the OR setup looks like. Posterior dissection. Rectovesical fold is incised. Seminal vesicles are dissected free. We have to be as athermal here as possible with minimum use of cautery. These are vas being dissected, clipped, ligated. The artery to vas being clipped and ligated. The advantage with a robotic system over a laparoscopic system is that surgeon is at much ease. There is tremor filtration completely, doesn't get fatigued. There is 10 times magnification. You have 7 degrees of freedom of movement, while as in a laparoscopy, you will have only 3 degrees of freedom of movement. In a robotic system with your arms, you have 7 degrees of freedom of movement. And you have 3-dimensional view. You have depth perception as well, which is not so much or at all in the laparoscopy system. A robot is actually an advantage for pelvic surgeries. This is the anterior dissection. I'll skip to the next video. In the previous surgery, we started with the posterior dissection first. In this, we'll start with the anterior dissection first. So this is the urachus being dropped. Bladder is being dropped between the both umbilical arteries, obliterated umbilical arteries, right up to the apex of the prostate. That is the pubic bone being visible. Laterally, bladder is dissected free. This is endopelvic fascia coming in picture. It's incised laterally as close to the muscle and as far away from the nerve and neurovascular bundle, because we intend to do a nerve sparing prostatectomy. This is the DVC being sutured. Now the fat is dissected free from the periprostatitic fascia, as we call it. This is the bladder neck incision, the bladder neck cut. It can be visually assessed by tucking the Foley's, which your assistant does from outside. This is a dissection being carried out. You use the cautery only where it is required. Mostly it has to be cold cuts and athermal dissection. No, these are posteriorly seminal vesicles being extracted out after giving posterior bladder neck cut. Now, whether you will be able to conduct a nerve sparing prostatectomy or not also depends on the patient anatomical characteristics and the local extent of the disease and his score about sexual potency and other things before surgery. The bladder plus being dissected and clipped. The seminal vesicles being dissected out. Vas being clipped and ligated. Now this is the anterior approach. Here we go anterior only and dissect it out. Here we have to be very careful about not injuring the nerves as they run very close to SVCs. So mostly athermal dissection, cold cut cautery. That is rectum being dropped. And we have to go right up to the apex of the prostate. Posterior dissection being completed. Going right up to the apex of the prostate. Suction irrigation. Blunt scissor dissection, sharp dissection. Being careful here to dissect away the nerves using as minimum cautery as possible, because this is what will later on result in a good continence and a good sexual function, potency. But again, as I told you, nerve sparing prostatectomy is subject to many other conditions like tumor conditions and patient's baseline characteristics as well. You can appreciate the freedom of movement that you have without actually fatiguing yourself. This is the DVC cut. Here you have to be very careful because the sphincter will be very close to it. Third arm is used to give retraction. And the main advantage over laparoscopy is that camera control is totally with the surgeon. You don't need an assistant to show you the camera. So you can zoom in, zoom out, pan out, go from side, laterally, above, below, and see it. I hope this doesn't look like too much of blood to you. This is 10 times magnified. That is the neurovascular bundle being spared. Actually, this is a partially nerve sparing. You have to preserve a good length of urethra before cutting for a future anastomosis. Lateral dissection being completed. So now coming to the anastomosis part, this is the first Rocco stitch which is being taken. This Rocco stitch is very helpful in controlling hemostasis. The post-op hematuria is less. Bladder neck contracture rates are less. And this is Van Velthoven technique of suturing it. We usually use 30 loop V-lock sutures. It's a braided suture, self-retaining. Usually 2 sutures are required for the anastomosis. And then bilateral pelvic lymphadenectomy will be there, which I think I'll skip. So RARP, there will be minimal pain, minimal blood loss. The hospital stays much shorter. There is minimal risk of infection. catheter is required only for 7 days as compared to 3 weeks with open surgery. Patient can return to work within 2 to 3 weeks, and the oncological control rates are high. This is a paper publishing various techniques of the robotic radical prostatectomy, whether you use a SP or a MP, that is a single port, or a multi-port robotic platforms. Specific techniques and approaches depends on the surgeon preference and the patient expectations as well. Nonetheless, the main goal should be to obtain a good oncological control. Nerve sparing RARP current perspective. Again, as I've already discussed with you, depends on patient characteristics, the anatomy of the patient and all. Anyhow, our main goal should be to achieve a good post-operative functional outcome for the patient. Sir, winding. This is a paper published after 13 years of the first prostatectomy, which was done in 2013 paper, and this established the role well. Urinary incontinence rates are 2 to 10% after robotic prostatectomy. Erectile dysfunction is around 10% and 1 year. Bladder leg contraction of 2 to 3%, and surgical mortality is acceptable less than 2%, 0.2%. And disease peak specifically is around 95% at 10 years. These are the broad comparison of robotic versus open results. The cancer removal is 97% as compared to 86%. Continence is as high as 96%, and potency is as high as 97% compared to the 60 to 65% in the open group. Quality of life assessment. In robotic surgery, it's earlier return to the baseline functions as compared to the laparoscopic 3 versus 6 months. And only in robotic arm, we were able to touch the baseline. This is the graphic representation of the functions. The treatment summary, I think I'll wind up here. Thank you very much, all of you. Thank you.
Thank you, Sandeep Mohan sir.
I think I was brief.
Yeah, but you were so good at your talk. So next session, we are honored to have Chairman Sir Gangaram Hospital Chairman Medical Oncology, Dr. Shyam Agarwal. So he'll be joining virtually. He's speaking on PARP inhibitors in CA prostate. And after that, we'll have that panel discussion and then lunch. Good afternoon, sir.
Dr. Shyam, you're on mute, sir. Kindly unmute.
So you can hear us?
Hello.
Yes, sir, we can hear you now.
Okay.
Okay, sir. Sir, it's echoing a lot.
Can you hear me?
Yeah, but it's echoing.
Hello. Hello. Can you hear me now?
Yes, sir.
So, okay, good afternoon. So I'm going to be talking about PARP inhibitors in prostate cancer. Thanks, Dr. Deepak, for this opportunity and inviting me. So can I have the slides, please?
Yes, sir.
Right.
can see
So
them.
can you go to the next slide? So PARP inhibitors are available nowadays for using in patients with prostate cancer. And this is
to be used particularly in patients who harbor mutations in the HRR gene. So you can see the inherited DNA repair gene mutations in patients with prostate cancer. So the incidence is from different series from 10 to 18%. And BRCA2 is the commonest, up to 50%. CHEK2, ATM13, and BRCA1. So these are the other three common mutations and this comes into the group of HRR gene mutations, which are the DNA damage repair mutations. Next slide. And again, to highlight, you can see the BRCA2, ATM, and BRCA1 gene mutations, even in patients with localized disease. Next slide. So interesting, and the important point is, like ovarian cancer, not only the BRCA mutations be germline, but they can also be somatic, which means that you acquire mutations in prostate cancer in around 8%, and similarly BRCA1 and ATM. So therefore, it is important to take a call as to what tissue we are going to test for the presence or absence of BRCA mutations. Next slide. So I think this thing on the germline testing is important for the patients who have family history of prostate cancer. Next slide. Or if they have a family history of breast cancer, ovarian cancer, and so on. So one can look at the blood test, because in order for us to test the germline mutation, a blood test is required. But then for patients with prostate cancer, usually we also tend to check the tissue, the prostate cancer tissue. Next slide. Because this may have a bearing also in the early part of the treatment, patients who have BRCA1 mutations, you can think of carboplatinum. Next slide. But I think the role is for the PARP1 mutations. So currently the FDA approves the use of somatic DNA mutations for patients with prostate cancer. And where the tissue is not available, we can think about doing the blood test or the liquid biopsy for somatic mutations. Next. So there are advantages and disadvantages. I'll not go into the details of this, but I think tumor is supposed to be the best. However, liquid can also pick up the BRCA1-2 mutations. Next slide. So why is it important to do these BRCA mutations and the HRR mutations is because olaparib has been approved in patients who are in the CRPC, as you can see here. And recently, in May 2023, olaparib and abiraterone was also approved in the first line for CRPC patients, for patients who have the BRCA deleterious mutations, whether germline or somatic. Rucaparib is also approved for patients in the CRPC setting who have the BRCA mutations, whether germline or somatic. So the point is that if you look for the tissue, then you can look for the BRCA1-2 mutations there. If tissue is not available, then one can go in for the germline testing also, or for the liquid biopsy also. Preferred is the tissue. Next slide. So this is some data from various studies, olaparib versus physician choice for patients with HRR gene mutations. So there are two cohorts, BRCA1, 2, and ATM mutations. On the cohort B is when patients have other HRR gene mutations, which are another 11, 12. Next slide. So as you can clearly see here, patients who had BRCA1, 2, and ATM mutations, olaparib is showing you PFS and overall survival advantage. Next. Whereas in the other gene mutations, the results were not that encouraging. Now coming to rucaparib versus placebo in BRCA1, 2, or ATM alterations. Next slide. And these are all patients with CRPC. A similar, curve is seen for the PFS. Next slide, showing you the benefit of rucaparib, and there is a similar benefit for OS for rucaparib. So olaparib and rucaparib can be used for CRPC patients who harbor BRCA1, 2, and ATM alterations. Next slide. So again, you can see the efficacy of these inhibitors is lower for patients who have CHEK2 or PALB2 or CDK2, or 12 alterations. As you can see, the responses and the progression is more for, CDK12 and CHEK2 and so on. So the genes which derive the maximum benefit are BRCA1, BRCA2, and ATM in prostate cancer. Next. So once we got the efficacy of these inhibitors in the CRPC setting, so then people thought of combining PARP inhibitors with these newer androgen receptor antagonists. Next slide, because there's a synergistic effect. Next slide. So PROPEL trial basically combined abiraterone, prednisolone, and olaparib in the first line for metastatic CRPC. Next. I'll skip the slide. I'll show you the data. So they looked for the HRR gene mutations, and 27% of these patients have HRR mutations. So that is the ballpark figure that almost 25% patients will have HRR gene mutations in patients with prostate cancer. Next slide. So now you can see patients who had any of these HRR mutations. You see the curves separate, and the hazard ratio is 0.5, and the median progression-free survival is not reached. Whereas patients who did not have HRR mutations, the curves are separating, but the hazard ratio is 0.76. So more benefit, which is expected, is seen for olaparib with abiraterone for patients in first-line metastatic CRPC who have not been exposed to abiraterone. Next slide. So this is the overall survival, again, showing you the benefit in the HRR mutated subgroup for combination of olaparib and abiraterone. Next slide. The side effects, I think, are by and large acceptable as we understand. Next slide. We'll skip this slide. Next slide. So on the same lines, abiraterone, prednisolone was combined with niraparib, and there are two subgroups of patients, either HRR mutations or patients without HRR mutation. Next slide. I think next slide. So it's a big trial, 200 patients here. So if you see the mutated cohort, HRR mutations, you see the benefit for all, all comers in patients who have HRR mutation, and more benefit for patients who have BRCA1/2 mutation, because the hazard ratio is 0.5, like you saw before. And for all mutations in the HRR genes, which are about 14, 15 of those, the hazard ratio is 0.73. Next slide. The side effects, again, are fairly well accepted. Next. Next slide. So now coming to the third PARP inhibitor, which is talazoparib, and this time it was combined with enzalutamide as a first-line therapy for metastatic CRPC, or enzalutamide was given alone, and the HRR mutations were tested. Next slide. So again, you can clearly see that the progression-free survival, or the radiological progression-free survival, gives you the progression-free survival benefit, and the hazard ratio is 0.63 for patients who are in the BRC or the HRR mutated category. Next slide. But overall survival is not significant. Next slide. So this is another study, that is the Triton 3 sequencing of rucaparib with docetaxel or the second generation newer hormonal agents. And as you can see, patients who have BRCA1/2 or ATM, the rucaparib is doing better than docetaxel, or rucaparib is doing better than the second generation ARPIs like enzalutamide and apalutamide and abiraterone. So in patients who are failed first-line hormonal therapy, in patients with metastatic CRPC with BRCA1/2 ATM mutation, rucaparib becomes one of the drugs like olaparib. Next slide. In front of these drugs. So because of these studies and these outcomes, you can see olaparib is approved as a monotherapy in metastatic CRPC in patients with BRCA1/2 and ATM mutations, and it should be combined, can be combined with abiraterone and prednisolone in BRCA1/2. And the issue is whether to use the drug in other mutations. So certain countries have the approval, some countries don't have the approval for mutations in the other HRR genes. Rucaparib is approved in deleterious BRCA mutation in patients who have failed the hormonal therapy, and the taxanes, you can use it prior taxane or even after taxane. Niraparib and abiraterone can be used in combination in metastatic CRPC in patients with BRCA1/2 mutations. Next slide. So I think PARP inhibitors are to be given to patients with relevant DNA repair gene mutations, particularly BRCA1/2 and abiraterone. If you don't have that mutation, next slide shows that the lutetium PSMA therapy can be offered for patients who have expression of the lutetium PSMA in their tumor on the PSMA PET scan. Next slide. So that's a new nucleide therapy which has become available to us for patients who are failing hormonal therapy in the mCRPC setting. Next slide. Next. So I think it is imperative, it is very important for us to understand that we should do the BRCA1/2 and HRR gene testing for patients who have castration resistant prostate cancer in order to decide whether PARP inhibitors should be given or not. Next. So the couple of slides. So it should be ideally done on the fresh tissue if possible. If not, then on the old tissue. If that's not available, then liquid testing or the liquid biopsy that is from the blood should be done. If all that is not possible, please do the germline testing for the BRCA1/2 gene. Next. So I think we discussed this issue. Next. So I think patients who have been pre-treated with the hormonal therapy and who have HRR gene mutations should be given the option of either olaparib or rucaparib, either alone or in combination with abiraterone if it has not been used before. So thank you very much for this opportunity, for listening to me. Thank you very much.
Yes, sir, you can.
Yeah, good evening, Dr. Shyam Agrawal, sir. That was a lucid presentation. This is Dr. Sandeep. Hopefully you are able
Hello.
to see me. Sir.
Yeah.
So most of the data that we have for the PARP inhibitors, it's derived from ovarian cancer, in which the drug has moved from the third line to second line to first line. And interestingly, the third line indication has been recently withdrawn. As compared to ovarian cancer, prostate cancer has much less BRCA1/2 positivity, and that's why the concept of HRR genes, ATM, etc. But even if we add them, it's only hardly 10 to 12% who will be having HRR mutation.
Right.
Now, when you are confronted with a situation in CRPC, high volume, high risk disease, and with a BRCA mutation, what will be your choice? Using a tab with the docetaxel based chemotherapy or plus minus platinum, or abiraterone plus olaparib, as you have already shown in the data that it is approved for this indication. You on one side have a targeted regimen, on one side you have a tested proven regimen for a high risk, high volume disease.
If somebody is having BRCA1/2 and particularly ATM mutation, then I think I'm tempted to use olaparib or rucaparib, either alone or in combination with abiraterone, even before docetaxel. These patients are elderly and they're usually not fit for chemotherapy. So, if you have not used abiraterone in the first line, because current treatment for first line hormone sensitive would include, either a new ARPI alone or in combination with docetaxel. But if the patient has a BRCA1/2 ATM mutation, I am tempted to put olaparib ahead of docetaxel.
Okay, sir. So what about patients who are not able to afford any PARP inhibitor? Although we have rucaparib as a generic and one of the generic for the olaparib as well. Suppose patient is not tolerating or not affording. So can we use something like platinum with or without the taxanes in such patients? Because BRCA mutation is going to give them platinum sensitivity as well.
Yeah, I showed you one slide there that, like ovarian cancer patients, you do tend to use platinum. Yes, I think platinum can be used. A combination of dosi or a carbo can be used. And I also showed you if it is a PSMA expressing tumor, kindly consider use of the radionuclide lutetium PSMA therapy also.
Okay.
So you got several options today. You got several options today for these patients who are escaping first-line hormonal therapy. So you can go for chemotherapy, you can go for PSMA therapy, and if the BRCA1, 2, or ATM is mutated particularly, you can go for olaparib or rucaparib. Or if you have other HRR gene mutations, you can go for a combination of olaparib and abiraterone if the gap for abiraterone is more than 1 year.
Thank you, sir. I think message is loud and clear. After BCR ABL, BRCA1 mutations are predictive of a very good response. So wherever possible, try to use the PARP inhibitors. Thank you. Thank you, sir.
Dr. Ilyas Sharma, HOD GMC Jammu, want to ask you a question, sir.
Yes, sir. I can't hear you.
Sir,
Am I audible now, sir?
Yeah, you're audible now. Yeah.
Sir, I want to know, once the in HRPC setting, what are the guidelines for testing for these mutations? Do you test all the patients who become, hormone refractory? And what are the costs involved in doing this test? I just want to know.
So that's a very good question, sir. I think if, as I showed you in one of my slides, if the patient has a family history of breast cancer, pancreatic cancer, colorectal cancer, or a prostate cancer, depending upon the age, one should do the germline testing in patients who are at high risk, number one, which is a simple blood test, takes 3 weeks to come in, and the cost of the test is about 15,000 or even lower, like 10,000. So it's a simple blood test. However, if the patient has no family history of any of these cancers, like breast cancer, pancreatic or colon cancer, then if the patient has regional disease or the patient has metastatic disease, so you should use the tissue preferably for looking at the BRCA1, 2, and if possible, the other HRR genes. And again, the cost of the test is again 15,000, and the turnaround time is only 2 to 3 weeks. So I think that is that. If the tissues, the problem is that these patients will progress, and the need for the PARP inhibitors will come after 3-4 years. Then the previous tissue which was done to diagnose is, it doesn't become, it comes as a negative report, which means that the DNA is not sturdy. So then you have two options. Either you take another biopsy and take a fresh sample. If that is not possible because the patients refuse, well, then you can do the liquid biopsy for looking at the BRCA1, 2 for somatic mutations. So that is the algorithm which we follow. But I think the guideline says, if somebody has nodal involvement or somebody has metastatic disease, at the same time, you should do the BRCA1, 2 testing from the prostatic biopsy tissue.
Hello, sir. In the initial biopsy, when we diagnose cancer, is it recommended to do all these tests, or we
Yes,
do
sir.
these tests?
Yeah, this is absolutely as per NCCN guidelines, that if somebody has regional disease, means if somebody has, that is a patient who has a higher chance of relapse. So if somebody has nodal involvement or somebody has metastatic disease, so it is recommended to do the BRCA1, 2 testing at that point itself. However, most of the oncologists actually, do the test after the failure of first-line androgen deprivation therapy.
Okay, sir. Thank you. Thank you very much.
Thank you so much, sir, for sparing your valuable time.
Thanks, Deepak. Always an honor and pleasure.
Thank you so much, sir. Thank you so much.
Thank you.
Thanks.
So now we come to the last session of the day. It's a panel discussion to be moderated by Rahul Sharma, sir. May I invite the panelists, Dr. Sandeep Batra, sir, Dr. Ajit Rathod, Dr. Shamim Ahmed, Dr. Sajal Goel, Dr. Aman Sharma, Dr. Gagandeep, Dr. Sushil. Okay. ठीक है sir.
Thank you, Dr. Satyankar. So we have the distinguished panelists. A medical oncologist is there, nuclear medicine.
So we have now our moderator, Dr. Rahul Sharma, who is also advisor trustee with LB and ROH.
Dr. Sunny Jandyal is a medical oncologist. Dr. Gagandeep is radiation oncologist. Dr. Ranjit Rathore is a urologist. Dr. Sajal Goyal. Dr. Ravinder Singh. Yes, not. Yes. Dr. Aman Sharma. So you are a radiation. So I will start with my first slide. So, my first question to Dr. Sandeep Batra. What is this oligometastatic prostate cancer? What is the definition? How do we say that this is oligometastatic or not?
So oligometastatic definition is not limited to prostate. Most of the cancers who do not have a very aggressive disease biology. The oligometastatic term is not restricted to only prostate cancers. It's all the not very aggressive cancers who have a limited sites of metastasis. And already you have shown in the slide itself, which is number varies from 3 to 5 metastases, not more than that. There is no visceral metastasis, including liver or other organs. Or when it comes to prostate, the bones and mold are only in the central axial spine, not the appendicular spine. So if these conditions are fulfilled, then you label them as oligometastatic prostate.
This is a definition which we have taken from Chartered trial,
right?
Where they defined a low burden
volume,
and
low
a-
risk disease.
Yeah, low risk disease. And this is
Incidentally, this also covers the definition for the oligometastatic.
there is another definition, which is the biological definition. Where it has been derived from one, there is Halstead theory is there, where it says that cancer spreads in the orderly fashion from primary to the lymph nodes and then to the distant metastasis. Then Fisher theory, which says that cancer is inherently systemic disease. And then there is the spectrum theory. My next question to Dr. Sunny Jandyal. So how do you explain this in terms of biological theories of this cancer origin and spread?
Actually, the Halstead was a breast surgeon. So he was a big advocate of extensive radical mastectomies. And they believed at that time that it spreads in an orderly fashion. Whereas Fisher proved that it's a systemic disease and the cancer cells are there in the blood even when the disease seems localized. So this is how the two theories are. None of them, both are actually hypotheses. None of them is proven correct. You see, in ocular melanoma, the disease is in the eye, but the first site of metastasis is liver. It does not follow an orderly sequence. So in cancer, it cannot be a generalization that the disease behaves similarly. Oligometastatic term actually was defined by the clinicians who thought that if the disease is not visceral, probably they have a better outcome. And it is not localized either for the surgeon to cure it altogether. So they devised a term whereby, and it only applies to the disease which are, which are low temperature, which are slow growing diseases, especially breast and prostate. These are the two organs where we especially use this term. So I do not subscribe to any of the theories because no theory particularly entails the entire spectrum of cancer.
So are these oligometastatic cancers, they biologically different from the widespread disseminated metastatic disease in prostate cancer?
It is the same question as whether a T1, T2 disease has a better outcome or were they prognostically low grade so as not to metastasize. So there is no one answer to that. We don't know whether it was a disease with the better biology that it did not spread to the viscera or vice versa.
There are three different clinical types of oligometastatic disease which have been described in literature. One is the de novo and another is oligorecurrent and oligoprogressive disease. My next question to Dr. Sandeep Batra, how do we treat them or how do we define them, and are their management different from each other?
So this is rather a continuum. A disease presenting as a metastatic at the time of its diagnosis is usually considered as an aggressive disease, and you need to understand the biology of the disease during the course of the treatment. Oligorecurrent disease has already shown its biology that it is not as aggressive. That's why once the disease is primarily controlled, then subsequently at a later point of time, there are some recurrences, but which are limited in number. The oligoprogressive disease, although the oligo term is there, but this disease has progressed while on treatment. That means that the evolution of the cells have occurred. They have acquired mutations which have made them resistant to the standard treatments. So if I have to prioritize into 1, 2, 3, as far as disease biology is concerned, so for me, oligorecurrent will be the best biology, followed by de novo metastasis, and last will be the most aggressive one, oligoprogressive.
These are the 5-year overall survivals in different kinds of prostate cancer. If there is a localized disease, the 5-year overall survival is in the range of 100%. Even if regional disease is there, it is almost 100%. In metastatic disease, it is 30%. Now comes the oligometastatic. The survival which has been reported in the different clinical trials is 50 to 70%. And it has also been seen that de novo low volume median survival is 4.5 years. In high volume, it is 3 years, and recurrent low volume is 8 years. So recurrent low, oligorecurrent is, they are surviving better than the de novo low volume. So my next question to Dr. Shamim, most of the trials, they have done conventional imaging while defining the oligometastatic disease. What is the role of PET-CT in redefining the oligometastatic?
Yes, most of the initial guideline and every other guideline which has still there, they says that do the local CT, abdomen and pelvis, then do the bone scan. And on the basis of that, you can say this patient has a oligometastatic disease or a progressive disease, or we can say having more than the 5 lesion in the body. But with PSMA PET-CT, I believe that everything has changed now. It will be a one-stop shop imaging, and I think this should be preferred where we have this imaging modality, because it is far better than the bone scan alone and the CT scan and the other all imaging modalities. So I believe that PSMA PET-CT, though it will take some time, it is coming into the guideline also, but it will replace all these guidelines. PSMA PET-CT is the gold standard, I believe.
Is it possible that because of the advent of PSMA PET-CT, we are diagnosing oligometastatic disease in the very high-risk group?
Yes, it
which
has
were
changed.
initially candidates for local therapy also.
Yes, it has changed because CT is a structural imaging. Sometimes we have the tendency to miss the small nodes, and the nodes which we can see on the size criteria, we will not be able to define whether this is a benign node or a metastatic node. When we have a PSMA scan, we can definitely tell this particular node is a metastatic. And sometime in the bone scan, there are chances that we can get a false negative scan, and that particularly common because the bone scan has less resolution as compared to the PSMA. So PSMA has high resolution and high, that will give us the functional as well as structural information, which we cannot get the conventional imaging like the CT and other.
Yeah, now this is oligometastatic disease management has seen a new paradigm shift in cancer treatment. Previously, it was said that if there is a metastatic disease, there is no need of doing local treatment, or to the metastatic also, we will do palliative treatment. But now we are trying to achieve cure in such cases. And there is a 3-pronged strategy for achieving cure in such cases, and we call it total consolidative therapy. Dr. Sandeep Batra, what is your opinion regarding this total consolidative therapy in oligometastatic prostate cancer?
So once you have understood the disease biology, you have to give them what there is due by increasing their survival, and that can only happen when you control primary as well as the metastatic signs. And the oligo term defines that since they are limited metastasis, your intention should be curative and not the palliative. And that's the evolution in thinking that has happened. And that's why now more and more patients are getting, if not cured, a very long-term control because of the control of the disease at all the stages.
So now I will come to a case of oligometastatic prostate cancer. A 63-year-old male, he presented with urinary retention. His PSA was 36.5. Biopsy showed Gleason 4+5 adenocarcinoma in all fours with extra prostatic extension. MRI showed a confluent pyrides 5 lesion throughout the left peripheral zone apex to the base, and PSMA PET showed intense uptake in sternum and left iliac bone. There were only 2 sites. These are some of the images taken from PSMA PET and from the CT. So there is a metastatic lesion in the left iliac bone and in the sternum. Is it an oligometastatic disease? Can you label it? It is a de novo and it is at presentation. So it is a metastatic hormone sensitive prostate cancer. So would you start with systemic therapy initially, or would you like to refer this patient to the urologist or to the radiation oncologist before starting treatment?
No, this is a oligometastatic disease. We will start with the systemic treatment first. And once we have the control of the disease at the primary and to some extent in the metastatic sites, then only we'll assess about the local control at both the sites. So it is not with the upfront surgery or upfront radiation, but a systemic disease to control the disease system.
So you will start a systemic therapy. So Dr. Sunny Jandial, what are the options in systemic therapy in this case? And how do you decide?
Depending upon the age, comorbidities, and the financial status. The patient is fit and we are looking for an aggressive option, then I'll add docetaxel to the anti-hormonal therapy, which I am already giving. And if the comorbidities persist, if there is a good response, as Dr. Sandeep has said, only then I'll proceed with the further plan.
If there are no constraints, what is the best regime which you will use in this case?
I think I'll use anti-hormonal therapy with docetaxel.
Okay. So you won't refer this patient for radiation to the primary or to the metastatic side?
Not immediately. Although this case will be discussed in the tumor board to plan the course of events. But as Dr. Sunny rightly pointed out, even I would prefer it's a low volume disease, ADT with either a abiraterone or enzalutamide based on the comorbidities. And after about 2 to 6 months of treatment with the repeat imaging and the biochemical testing, once we have got a PSA near the normal range or normal range, and the disease sites are quiescent, then we will consider it for the artery to the primary as well as the metastatic.
My next question to Dr. Ranjit Rathod, who is the urologist here. You have diagnosed this case, oligometastatic prostate cancer, and you have seen this case. Would you like to refer this patient for systemic therapy to medical oncologist, or would you like to attempt a cytoreductive prostatectomy first in this case?
Yeah, since the PSA is very high, it's only 36.5. So I don't think that this local therapy will help too much. But recent studies, they have shown that, especially in few centers in Delhi, they have shown that even in this stage, by doing the debulking prostatectomy, if it has not been done earlier, if you do radical prostatectomy, it will help in overall improvement because of 3 factors. One is because of anti-tumor response. Second is increasing the overall survival and decreasing the micrometastasis. These are 2-3 factors.
Yeah.
But this is not a multi-center study. Few centers are trying, they have shown few results.
Yeah, Mayo's clinic data is there. Then there is a trombone trial and another trombone phase 3 trial. It is ongoing. This radical prostatectomy for oligometastatic prostate cancer, the trombone trial has been published in 2022, where 51 patients were enrolled. The full name is Testing Radical Prostatectomy in Men with Prostate Cancer and Oligometastasis to the Bone. And it was seen that quality of life was similar in those having prostatectomy versus those who were not having prostatectomy. And the doing radical prostatectomy
No,
in
this-
such cases is
This
safe.
patient is having retention.
Yeah.
He is in acute retention, he's on catheter. So how you can say that quality of life? If we do a surgery, so definitely he will be free of catheter.
Yeah, retention. The patient presented with urinary
So it
retention.
is so painful for a patient who is a continuously our patient. So when you do a cytoreductive, so you will not increase the overall survival. It will not increase, I'm sure, because there are metastasis maybe in the regional as well as in the bones. It will not increase the overall survival, but it will increase the quality of life.
But you will do cytoreductive
Yes,
prostatectomy.
but we'll take into consideration other parameters.
Whether it improves survival or not, that will be answered in the trombone phase 3 trial.
Okay.
It has not been published yet. So
My question
at
is
present, I'm saying that
quality of life.
prostatectomy is an option in this case.
Cytoreductive, yeah.
Dr. Sandeep, but
No, I would say that if you have to give the symptom relief, you can go for the TURP. Since it was a locally advanced disease and metastatic as well, we do not have the data in favor of doing a surgery after neoadjuvant hormone therapy. And data is abundant for doing the radiation after neoadjuvant hormone therapy. So rather than using all three modalities, systemic therapy, surgery, and then radiation and continuation of hormone therapy, I will limit myself to not using surgery except for the symptom control. Specifically because it is not shown to have increased the improved survival. Rather, you will give toxicity of all the three treatments in the form of at the local site as well, incontinence and other things. So I will reserve surgery for any unanticipated, unantecedent condition where surgery can be offered. Otherwise, I will restrict myself to two modalities of treatment.
there is another trial, Southwest Oncology Group trial. This is also ongoing, where they have randomized between standard systemic therapy versus standard systemic therapy plus radical prostatectomy or radiotherapy to the prostate, plus metastatic directed therapy to those having less than 4 sites. This is done before randomization. So I think this trial will also answer the question whether it makes a difference to the survival or not. Then coming to radiotherapy to the prostate. Dr. Aman Sharma, would you like to offer radiotherapy to the primary tumor in this case?
Yeah, I think firstly, it's very important that all the stakeholders together discuss the case in the multidisciplinary tumor board with the urologist, with the medical oncologist, with the radiation oncologist, and then the plan is made combined. So that's very important, and hopefully all the three concur to a similar plan. Of course, and it needs to be discussed with the patient. As you mentioned about the Stampede trial, I think radiation is a good option and it would improve survival. So that's important and it should be offered. Also, it's important not only to offer radiation to the prostate only, but also to metastatic sites. So it would be a complete ablative package, unfortunately, which has not been done. And the doses of radiation in the HORADS trial and the Stampede trial, I would say they have been a bit suboptimal. So I would do all the ablative doses to all the metastatic sites. And of that, I think that would be more important because you have to be very clear with the intent. If you want to cure the patient, you have to do a good ablative radiotherapy at all sites. So that's very important. Also, there has been data which suggests that because all the treatments have their side effects, so there are patients who do not want to like go in for systemic therapy upfront. So people have explored giving a radiation to the primary and the metastasis, and
There are few trials which have shown that progression at 6 months, only 40% progress versus in the observational arm, 80% progress. So also we have to take into account the patient. We have to explain all the side effects and give an option. What are the options, and let him choose. We have to empower the patient, and we may give options what is right, and then let the patient choose. From my point of view, I would definitely offer radiation.
In Stampede, it was the standard therapy with ADT plus docetaxel versus standard of care plus radiation. And they gave radiation 36 gray over 6 fractions over 6 weeks, or 55 gray over 20 fraction. Would you like to stick to the same schedule, or would you like anything different in this case?
I think I would not like to stick to this schedule. Also, the Stampede trial is not designed for oligometastatic disease. That's very important. It was designed for a metastatic disease.
But they did subgroup
And
analysis
yes,
in
yes,
low
yes.
burden versus.
Yes. So they designed with an intent that the radiation to the primary would improve survival. So, but here the intent is we are going for a complete ablative therapy to the primary and the metastasis. And when you're giving the dose, I would say is a bit suboptimal. So I would go in for a higher dose, probably SBRT to the primary and to the metastasis. Thank you.
Because it has been shown in the this subgroup analysis that low metastatic burden disease, the overall survival and failure-free survival, both are improved. We can see from.
Yes, I think you are very rightly mentioned it. And also we need to see when you're looking at the thing that what is the non-cancer mortality. So if the failure-free survival is improving and the OS is not improving, we need to check. Probably the authors have not mentioned it, why the OS is not improved. And also it's how you're calculating the sample size. So it's 2000 patients. If you say it's 8,000 or 10,000 patients, then probably the OS would also be beneficial. And with the newer how we define the oligometastasis, and the more accurate we are in defining the oligometastasis, which has an indolent biology, and then we target that in those subset of the patients with the adequate radiation dose, I think more encouraging results would come, because the local therapies are evolving, and our knowledge of the oligometastatic state is improving day by day. So it's like, as you mentioned, with the PET scan, now there are other tracers coming that are even more sensitive and specific than the PSMA PET scan. But I think I would, we have to abide by the evidence, whatever it is. At the moment, I think a low risk disease is the one that we should be targeting with radiation.
Stopgap meta-analysis has also been published, which has shown that there is 3-year survival improvement by 7% with radiation therapy in those having less than 4 months. And 3-year biochemical progression-free survival improved by 10%. So I think the radiation is an acceptable modality to the primary, and let us see what to the metastasis. Now, Dr. Gagandeep Singh, would you like to give radiation to the metastatic sites also, to the sternum and to the ileum in this case?
SBRT should be given. SBRT should be given, sir, to the sternum and other metastatic sites.
Would you like to give a SBRT? Does it have any advantage over other forms of radiation? What is the advantage of SBRT over other forms?
Sir, it will spare the normal structures.
Yes.
If we are giving radiation.
But that can be spared with other modalities also.
Sir, if we are giving SBRT to sternum, we will spare the cardiac tissue.
It has been mentioned in literature that there is immune response, which is responsible for some additional tumor control, especially in those cancers where there is low alpha beta value. And this is besides the localized cytotoxic effect. Now, my next question to Dr. Shamim, instead of giving systemic therapy with hormones and chemotherapy, can we give radioligand therapy in this case?
I will say no. The reason being that it is appropriate to follow the conventional method first, and then if the patient has a resistance to them, then we can only consider for the radionuclide therapy. Though the many trials are coming where we are opting the patient with upfront other drugs plus the conventional medicines and the radioligand therapy. We can say PSMA therapy or lutetium-based therapy or alpha-based therapy. But as per my perspective, I will say that first we should try all these the conventional therapies. If the patient is not responding to them, we can keep this for the later
Because
phase.
I'm asking this question because it has already been approved in USA for PSMA positive, but castration resistant prostate cancer.
Yes.
And there is another trial going on, Bullseye trial, which is enrolling patients in metastatic hormone sensitive prostate cancer. In the upfront setting, they are giving this
Even at All India Institute of Medical Sciences, New Delhi, we are also giving this upfront lutetium, but we are just in the phase of means.
And in therapy trial, it has already been shown in castration resistance that lutetium 117 is superior to cabazitaxel.
Yes, that's true. But my perspective in these type of patient is that we should treat them with conventional therapy, because following a particular line of treatment will be up, because this therapy we can keep for the later stages, because these people are not going to have a fast progression. So we can try the conventional method. We can keep this for the future.
Yeah.
That's my perspective. Otherwise, we can give. You are absolutely
we can
right.
wait for the results of Bullseye trial.
Yes, we need to wait for these results to come, basically.
So my next question to Dr. Sandeep Batra. I think the hormone therapy is being challenged by the radioligands in the near future. Do you think it in near future?
Considering the dependence of prostate cancer on the testosterone, hormone therapy is and will never be challenged by the radioligands. If you have to give radioligands, it has to be under cover of a systemic therapy in the form of androgen deprivation. That's the crux of the treatment.
But they have challenged the chemotherapy.
Okay, so chemotherapy,
resistant.
cabazitaxel per se, I think most of the medical oncologists, although have used this drug, this is a very toxic drug. It's difficult to manage the toxicity, especially since it is into third and fourth line, because we have abiraterone, enzalutamide, docetaxel, and some patients with the BRCA mutations, PARP inhibition. So it has already gone to the back. So when you don't have other options, and when you don't have the radioligand options because of the unavailability or finances, then we use this drug. Now, there is something about the radioligand. I am not against them, but if you see the trial, it increases the overall survival without having any significant effect on the PSA. Now, prostate cancers, right from their diagnosis, are tuned to the PSA. If the PSA level is rising, their anxiety rises. They are treating oncologist, anxiety also rises. However, in these prostate ligand trials, that PSA was not the one parameter which was controlled. Okay, so quite strangely, it improved survival, it improved symptoms. There was a decreased requirement of the pain control drugs, but PSA was never a control endpoint in such things. So I think that also points towards that probably this therapy is still not going to be in the upfront setting. It is going to be after the failure of the standard hormone therapies.
I will actually, as per our experience, PSA response we have seen with the radioligand therapy, and we see in almost every therapy. It is not that PSA level will not go down with this therapy. Or as you have already mentioned, Dr. Sandeep has mentioned that overall survival and other progression-free survival has seen to improve with the lutetium therapy, but PSA level do fall accordingly with them back. Though, in our experience, we have seen the PSAs go down very drastically in these patients.
One thing, as Sir has rightly said, that if we see the comparison is with cabazitaxel, it's already a third, fourth line drug. By that time, the patient already has a lot of bone metastasis. The ability to tolerate the drug is very poor. So the first line, had it been a head-on trial with hormonal therapy, then things would have been different. So you need the backbone of hormone deprivation for a cancer which is hormone sensitive. It is analogous to we are treating CA breast who is ERPR positive, and we are saying we will only control something but will not touch the ERPR status.
I think that will be answered by the Bullseye trial, where they are going to. It is a head-on.
Yeah, I agree with you.
in the third line.
See, no, you are right. Prostate cancer gradually will show resistance to every and each therapy. It will develop resistant to the hormonal therapy. It will develop resistant to ADT. And then gradually we have to shift to the chemotherapy. The question here is not that we should replace the hormonal therapy or we should replace the anti-androgen therapy. The question here is that whether should we go for the lutetium-based therapy or the radioligand therapy, or we could go for the chemotherapy. So here, these things are under observation still. We are doing research on this also, and this will actually come up with something where which one is better than that. But nobody is asking to replace the hormonal therapy. So the competition is not with the hormonal therapy. So competition here is with replacing the chemotherapy with the lutetium therapy. So in that scenario,
so I think we need to understand that once a patient who has been exposed to abiraterone, enzalutamide, docetaxel, and sometimes some of our colleagues are also using Hornman for whatever benefit it gives, how many patients will be having asymptomatic or minimally symptomatic bone metastasis, which is the most important inclusion criteria for the lutetium therapy? A patient with a visceral disease or a widespread bony metastasis, as Dr. Sunny pointed out, which are usually symptomatic and they are only pain controlled with morphine analgesics, will the patient will be more appropriately treated with the lutetium therapy, or we will need to give a systemic therapy? That's the question that decides. So if it is pulled into the lutetium therapy is pulled into the earlier lines of therapy, when the number of bone metastases are limited, they are asymptomatic or minimally symptomatic, then probably lutetium will be a better option than the systemic chemotherapy in such patients.
I think what I feel is that now it's not how we are giving treatment is based upon the evidence. So whenever a robust evidence has been generated, I think all the specialties, whether it be a urologist, medical oncologist, or radiation oncologist, whenever new therapy has come, I think we all have been open to it and we accepted it in benefit of the patient. So if there's something which is new and it's benefiting the patient, I think all the modalities will happily accept it. Thank you.
And Dr. Shamim, is there any difference between alpha emitters and beta emitters, radium-223 versus this lutetium?
yes, of course, beta emitter has less effect as compared to the alpha emitters because they have high killing power, they have better range, they are more specific, their target is within the tissue, and they have high efficacy, and they have in fact they are more response as compared to the beta therapy because of their range, because of their kinetics, because of their pharmaceuticals characteristics, all of because they have a better range, they have a better killing capacity. So alpha emitters are always preferred over the beta emitter, the lutetium therapy. But the problem here is that lutetium we can get in 20,000 or 25,000 in India, but the actinium therapy per dose will cost approximately 5 lakh. So the cost has a huge impact on this decision. But otherwise, the alpha emitter are better than that.
Can we think of ablating the prostate primary with these alpha emitters? Just like in well-differentiated thyroid cancer.
Maybe a future thought, but at this point of time, no.
This is the extend phase 2 trial, which has been published in JAMA Oncology 2023, where they used external beam radiation to eliminate the metastatic disease. In oligometastatic cases, they used hormone therapy for more than 2 months, and then intermittent hormone therapy plus definitive radiation therapy to all sites of disease. And they found that median eugonadal PFS was not reached in those who received radiation versus 6 months, and median PFS not reached versus 15 months. So statistically significant improvement with the treatment of metastatic sites with the radiation. Dr. Sandeep Batra, what is this median eugonadal PFS, and is it clinically relevant marker?
So
intermittently
frankly, I am hearing this term first time.
Testosterone levels, they remain in Dr. Sunny Jandia.
This means actually, basically, it's just like that we are not hormonally ablating the patient of the testosterone level, and we are just using one modality over the one which has already been established. So we are trying to prepone radiation over hormonal therapy. So this is what the gonadal status remains the same, and the progression of survival, as Sir has mentioned, is not reached. So maybe that is one experimental whereby we will be interested in the results.
So this was my last question. I think this panel discussion is over now. So, thank you, everyone.
Thank you so much, sir. I think we are right on time. Just 10 minutes of more activity and I hand over the mic to Dr. Deepak Abrol for further proceedings.
Well, now we. Now we start with valedictory function. I invite our special invitees, Mr. Rehan Hussaini, our facility director, Mr. Rehan Hussaini, and regional AGM finance, Vikrant Singh ji on dais. Please give him a big hand. Conference is because of finance minister always. Facility director, Mr. Rehan Hussaini Khan. Wow, sir, I asked you to wear pink, so you are in pink. So we'll start with the proceedings. There are a lot of people who have put in their hard work and arranged finances for this conference to happen, without whom this conference wouldn't have been possible. So we just wanted to thank them and pay them regards and give them a token of appreciation. There are always a person from arranging hall, arranging LED wall, arranging cameras. They are all important, without whom this conference wouldn't have been successful. And I want you to give big hands to Rahul and his team, because they have performed this function. Even a single glitch hasn't come. Thank you, Rahul. Even virtual, when Dr. Shyam Agarwal joined and people interacted with him, this was so flawless that I had attended so many conferences, Dr. Satyankar, and all of you have attended so many conferences. We haven't seen such a wonderful. Thank you, Rahul. So please bring in your team so that we can, Rahul and his team. And I invite Rehan Hussaini sir and Vikranta to honor them. Now I invite our marketing team of American Oncology Institute, Vigat, Ashutosh, Anil Rana, and the person who has put in all his heart and soul. Where is Sahil? Transport minister is the most difficult job, now I understood. He is still arranging taxis, so we'll अनिल आप आओ ना यार, कैसे बुलाना है, लेट हो रहे हैं. आशु, आप इधर ही रहो सर, आप बैठो नहीं. The team of KC Hotels, Rawat ji, Dogra ji, and please sir come.
We'll appreciate the hospitality given by the Royal Park team, and all credit
Mouth-watering delicacies also.
and all the credit goes to Rawatji and Dogra sir.
And of course, our dear friend Rahul Jandial. Please come. डोगरा साहब हीट ऑफ मूवमेंट में अगर कुछ बोला गया हो तो सॉरी. Next, I invite our pharma colleagues and industry partners, representative from Fresenius Kabi. Jaldi, please, jaldi aa jaye. All pharma colleagues, please come forward. Fresenius Kabi, Medilif, Novartis, Pfizer, Samarth, Sun, J&J, Cipla, Atulya Healthcare, Agilus, Jammu Healthcare, BDR, Aureate, Biocon, MSD, Intas, Zydus, Amcure, Roche, Strands, Vembrace, Punjab Motors, Mercedes, Elnish, Examed, Pius, Swastik, Pharmagon. Pairing.
यार पिक्चर्स लेने हैं आपने सबका, हाँ? नहीं, one by one. हाँ, one by one. Sir, everybody. नहीं, one by one. Fresenius.
एक-एक करके आते जाओ सर.
Fresenius आगे, हाँ, ठीक है. Thank you, Farooq. Anybody from Medilif Pharma? Novartis? नहीं यार, चलो. Asrar from Pfizer. He's traveled all the way from Srinagar. Insha from Smarth. Anybody from Atulya? Varinder is here.
MSD, come forward.
MSD नीचे है ना, तो मैं order में बोल रहा हूँ. Order. नहीं कोई गल. Gurmeet from MSD. Thank you so much. Varinder from Atulya Pharma, Atulya Healthcare. Anybody from Agilus? Okay. Aureate. I think Sahil was here. I think he's busy with transport.
Transport वाले सारे busy.
Anybody from Intas? No, he's also busy with transport. Zydus, Amcure. Yeah, please come.
Come.
All three of you, not a problem. Okay. Amcure. Okay. Sahil from Roche. Sahil. Strand Life Sciences. Vembrace. I think nobody's from Mercedes. Okay. Elnish Pharma. Examed Diagnostics. I think they've left. Jammu Healthcare, Pius. Somebody from Pius? No. Swastik. Left. And Ferring Pharma. Anybody who's left? J&J, yeah. मेरे से miss हो गया.
Any more if it's not in list because we have created it in hurry, please come forward.
Thank you so much, sir. Thank you.
Now, the persons, my dear friends, who have carried out the message of this conference throughout the world, I can say, by their writings. The media colleagues, I invite my media colleagues. Rohit Jandial ji, please come. Editor, Dainik Jagran. Rohit Jandial ji, editor, Dainik Jagran, who has covered this event, and the news in Dainik Jagran is coming from last 5 days. Thank you so much. Lalit Khajuria ji, Chief Editor, Jammu Samvad. Everybody knows the famous voice, Namaskar, मैं हूं Lalit Khajuria. Amit Tajrawat, co-editor. Naresh Sharma. Red FM, who are our cancer awareness partner, any representative? Red FM, Sarang. कोई और मीडिया colleague और कोई है? नरेश हो गया. Now, for last, Sahil, sorry. Yaar. Most efficient and most hardworking. Vigat, Mr. Vigat Chandan. We have representative from Agilus who has come, Pharma. Please come. And you are getting mails from last 2 to 3 months, coordinating team who was coordinating for CRABECON, Mighty Deo team, Ravindra Purohit along with his team. I think one is missing. What is his name? What is his name? Shresht. Ravindra Purohit, Sunidhi Kohli, Mighty Deo. Shresht. Prince, who is our PR expert for the trust, making all the press releases. Now I invite, please take seats. Please take seat. I request Secretary of the Trust to honor Rehan Hussaini ji, our special invitee, and Vikrant Singh ji, our special invitee. Dr. Satyankar. Now the two persons who were distributing the trophies since 3 days, Shirin, आपने खुद ही ले आओ. शीरीन एंड यासिर, ले आओ. अपने लोग हैं, कोई बात नहीं. Dr. Satyankar, please for INTAS and R8, you please honor them. इधर आ जाओ, इधर से आ जाओ. In every CRABECON, one person is there who look after rooms and transport, and he is Vikrant from INTAS. Thank you. Sahil ने इस बार किया है, but he is doing since long. Sahil, thank you. वो तो INTAS ही है ना. उसे लिखा था, उसे पता होना होता है, मान लो तो सजा करेंगे. About. Now, the much awaited results. We have kept competition for postgraduate students and PhD scholars. Every year we keep. This year what we did was we asked for abstracts and they have to present e-posters, and from e-posters 5 best abstracts were selected and presented today, and from them judges selected 3 best posters of posters and oral presentations, combined scores. And the third prize goes to Rajeshwar Singh Jamwal. He is from Mata Vaishno Devi University. He's a PhD scholar. Third prize. A medal, gold medal, LBN gold medal, and a check of rupees 10,000. Please give him a big hand. Sorry, 4,000. This is third prize. The second prize goes to Dr. Tanvi Mittal from Himalayan Institute of Medical Sciences, silver medal, and a check of rupees 6,000. And the first prize goes to Dr. Surbi Negi from Himalayan Institute of Medical Sciences. The Punjab Motors, Mercedes, were put in the stall under CSR initiative and helped us in organizing this cancer awareness camp. Thank you so much. Mr. Vigat, if he has come. Whole hall management was done by Vigat, and whole show belongs to you. Thank you so much. And Ashutosh, please, you also come forward. These are 2 gems we have at AOI. रविंद्र, आपको मिल गया ना? और कोई रहा तो नहीं? पता? अनिल, Harshit? Uh, and we also invite representative from WCC, World Cancer Care, who have arranged buses. Representative from World Cancer Care. I invite everyone for a group photo over the dais. Everyone, please come. Please come for a group photo. वाले आ जाओ ना इधर सेंटर में। Sir, please. Sir, please. One group photo. Make all the guests upon the stage. Stop, stop.
Figure, sir.